Good afternoon to everyone. I certainly want to welcome you to the Board of Managers meeting this afternoon. We're going to go ahead and get started. We have two additional directors en route. So again, welcome to each and every one of you. Appreciate the large attendance today. Our first order of business will be, is Leanne here? Sylvia, yes.
Sylvia is going to come up.
Hey, Sylvia, you would come up and their invocation, and after that, if you'd please join me in the Pledge of Allegiance, we will look forward to getting this done. Thanks, Sylvia. Come right on up, Sylvia, you're first. Thank you.
Good afternoon. Will you please join me in prayer? Most gracious and loving God, we come to you today asking for your guidance, wisdom, discernment, and support. We thank you that we have this opportunity to have this meeting, and we ask that you would be with us. Guide our hearts, our mind, in the spirit of fairness, right thoughts, and right speech. Help us to remember that all that is done today is done for the purpose of transforming healthcare delivery for the communities we serve. Thank you for helping us to accomplish the mission you have set before us. We pray all these things in your holy name. Amen.
Amen. Thank you.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Are you going to say anything about the people, what we helped out with as hospitals or anything or not? This is you. No, absolutely. No, I was going to say my other colleagues. I am told that there is no one who signed in today, so there's no one wishing to address this board. So we'd move to item number 4 on the agenda, which is the approval of the minutes. If there's any comments, we'd certainly take those this time, or any recommended changes. If not, I'd entertain a motion. I have a motion and a second by Dorothy. All those in favor say aye. Aye. Opposed, no. Thank you very much. Item number 5 is the board chair report. We have a very lengthy, I believe, board today, so I won't say too much other than to say that I'd be remiss if I didn't say and acknowledge what's happened in El Paso this week and Dayton and other places and those hospitals. And I talked to Robert. I was out of state, and I talked to Robert. I know our staff's here, certainly willing to provide. There's been blood drives. There's been all kinds of things. So again, to our colleagues in other cities, we certainly, they're in our thoughts and prayers. And I think, Robert, again, to you and the entire staff here, thanks for your concerns and things. You're reaching out. So thank y'all very much. And I know it's a lengthy, Robert, meeting today. So with the budget, I'm going to go ahead and pass it this time.
You bet. Thank you, Mr. Chairman. And to that point, as a level 1 trauma center, our trauma team is so incredible about how they reach out. A couple of years ago when we had the devastating tornadoes in Moore, Oklahoma, the first thing that Dr. Gandhi and our trauma team did was reach out to their trauma department, and that is basically the protocol at JPS. Even if you're 500 miles away or whatever the situation is, we try to make sure that we let our services be known, but let our hearts be shown. And so that's what we do at all times in trying to help out in those kind of devastating situations that took place in Dayton and El Paso, and then those natural disasters that take place from hurricanes, floods, and tornadoes and everything in between. We do not help out with the hot weather, but everything in between we will do our best with. Actually, we probably do help out with the hot weather. We bring a lot of people off the street and hydrate them. And we actually have a water giveaway program at our foundation to help folks. So we probably even do that. A couple things I wanted to mention to you. On Tuesday night, although to the sadness and dismay of Dorothy DuBose, because for the past 12 years, Dorothy DuBose has been an honored judge at our talent show. And she was very upset when we did not have our talent show this year. But the challenge was we were quite frankly running out of talent. It was tough because we have the talent, but everybody who was in our talent show had been here quite a while, and they had been part of talent night. So what we found in our last 2 years is we were having a lot of employees who had been here for 2 days who were part of talent, and we realized that in our orientation process, Pia would say our talent show is mandatory. So we have decided to make a change this year, and on Tuesday night, we actually had a JPS game night. And we went out to the pavilion at the zoo, and we just had fun. We had our physicians and providers against our nurses in a game of Family Feud. I will tell you that the bragging rights go to our nurses. It was hotly contested. We had a referee review after it was over, and the nurses won on what the doctors are calling a technicality. So the smack talk will continue for another year. We had a variety. We had the JPS Price is Right. We had a variety. We had Minute to Win It. We just had fun, and we had 1,500 members of our staff and their families come out and enjoy. You know, if anybody were to say, why in the world would you do that? It's somebody that hasn't worked at JPS and been in a trauma center. To have an evening of laughter and fun and just enjoying yourselves is what we did. And you've not seen anything until you see the executive team as synchronized swimmers. We have redefined synchronized, but they did come out and do their best. It was a form of synchronized swimming, and if Michael Hochberg wants to tell you his role, I will allow that to be there, but we did make a rule that said what goes on at the zoo stays at the zoo. So nonetheless, it was a very enjoyable evening. And I want to tell you that to have an executive team like that is more willing to make fun of themselves and enjoy things for the betterment of 1,500 staff members says a lot about the team that I'm lucky enough to work with. So, Dorothy, we will keep you informed, and next year maybe you can play the key role in Family Feud, so we don't want you to be upset.
Robert, I just want to add one thing. I very seldom invoke the privileges of the chair, but my 3 years as chair, I have to say it was so great having Dorothy as judge, because Ralph, you've been chair, I have too, over the years. It's a great event, and the one thing that you listen to Robert, he said it very quickly, but he really meant it, and their families. What's really enjoyable at this event each year is it's the true JPS family. So again, with everything else you do, with all the cares you have in this community, I think it's great you spend a night and say, hey, this is something for our employees and our family. So I commend the staff for one other thing they do. So
we had three amazing people along with Pia's leadership, but we had Chris and Carla and Lexi, who are three individuals in our HR team that put that evening on for us, and they did a wonderful, wonderful job. So kudos to the team and everybody else coming out and having fun.
And Dorothy, I think he nominated you to be a judge again next year. I was fine with that. So anyway, thank you. Go ahead, Robert.
I will say, and I don't think Dorothy will mind us, but usually when I introduce the judges, I really literally make up some story. And one year I made up a story about Dorothy being an Olympic swimmer and the 3 gold medals that she won at the Tokyo Olympics. And there was an individual dear to her that came up to her and said, I never knew that you were an Olympic swimmer. And I applauded Dorothy because she didn't deny it. She walked off. She swam away, and it worked really, really well. So I appreciate that, and I appreciate her tolerance of me. Tomorrow we have a wonderful function taking place at JPS. As you all know, we were we enlisted early on in some of the protocols and procedures of the Studer Group and trying to figure out how to make JPS a better organization. They gave us some guidelines. We hired them for a short period of time to help us out. This was way back in 2010. We have not been a Studer organization. We were a Studer organization probably for 3 years. And maybe 2.5. We are not a Studer organization, but the reputation of JPS and what we've been able to accomplish and what you and board have directed us to do has made a significant difference. And we have a visiting group of the Studer executives from Australia and 21 of their providers coming tomorrow to watch and see what we do at JPS. We are one of 2 hospitals in the United States that they chose to spend time at. So that's impressive to our team, and I'm thankful that Studer will join us to see some of the things that we do, and we've expanded a lot from what they suggested to us. And I think that will be nice, and I'm appreciative of that. You all can see on our portal some of the foundation grants and gifts that we've received. We've had an opportunity to receive some wonderful things from nursing scholarships. We had our first cohort donations of helping our nurses with funding for nursing schools, and that's been hugely powerful to our nurses. Wanda and the team went through a process of interviewing folks, and the donor to that was so kind to us that all applicants got into that process and will have tuition paid for their nursing school, which is really powerful. And we're really thankful for that. We've got a Healing Wings transportation grant for those AIDS and HIV patients that have a challenge. We got a $15,000 grant to help in that regard. We also received a grant through some of the work of Zelia on a suicide navigator to help us with people that are struggling, and also help us with some of the data recovery that we need, that we received from the Harris Foundation. So we've gotten a few nice grants and foundation work in to help some of our more vulnerable patient base. With the legislative process being over, there is the time to look and see what they've done. And it is a challenge in some cases. Some might be puzzling as to what they've done, and some we may applaud, and we're very thankful for what they did in some areas, and some we're still trying to define. But we are not the implementers of the legislation. We did not invite the legislation, but Senate Bill 1640 was passed, which is an attempt by the legislature to deal with quorums and open meetings. And so I originally found out about this while attending a meeting at the county, where the county suggested that they were not going to get the briefings that Sharon and I traditionally make to individual court members, because they felt that was in juxtaposition to the new law. The new law had an immediate effect, which, Steve, if you'll remember your days as a staff member, probably less than 1% of all legislation gets an immediate effect. There has to be a significant reason for immediate effect, because it takes a supermajority of both the House and the Senate to do. It's not easy to get an immediate effect. This bill had an immediate effect, and it will affect every governing board. With my counsel and talking to Robert Browder, and let me introduce you to Robert Browder. He's sitting next to Sharon. Robert Browder joins us. He's in his 8th day, and he has chosen to come back. I asked him this morning. He's coming back for a 9th day, and I'm very pleased with that. I've talked to Robert, and I've talked to Neil, and both of those 2 lawyers agree, and we chose to take the path of not communicating with you prior to the budget, which was difficult and challenging. That's not what we wanted. But we felt that if we did, we were putting you as a governing body member at risk. So without being trite, I'm going to take the balance of my time and transfer it to Mr. Adams. And so Mr. Adams can give you a briefing, and those of you in the community as well. If you're watching us live streaming, or those of you in the audience, if you're members of a governing board, this will apply to you. And you need to recognize this because it is a serious piece of legislation. So if you wouldn't mind, Neil, if you would give a briefing, and the last thing I will say, if any of you are frustrated by this legislation, slightly frustrated in any way, none of us on this staff wrote the legislation or had any input to this legislation.
Nor did your general counsel.
Nor did general counsel, nor did in-house counsel, nor did anybody we know, nor did any of our relatives.
Yeah.
So, Mr. Well, I understand,
that's the issue,
but
yeah.
we will not take that up with them, but you certainly can, Mr. Zimmerman. But, Mr. Adams, if you would.
Yeah, I'll very briefly comment. for years, actually, I guess since maybe, well, I don't think it was originally in the Open Meetings Act, but certainly early on, the statute adopted some provisions that address what's referred to as a rolling forum, where less than a quorum of the board is discussing an issue that is either on the agenda or could be on the agenda. And that's pretty broad. And for years, that particular provision in the statute's been there. This statute carries criminal penalties, fines and jail time if there's a violation, and the criminal penalties are addressed to the individual members who violate the statute. And going back to governing boards, it applies to any public governing board, whether elected or appointed. And so you're clearly under the act, and we've operated under that for years. A bill was filed, Senate Bill 1640, prompted by a case where a county judge in Texas was indicted under the previous statute. That case ultimately was appealed to the Court of Criminal Appeals, and they deemed the current statute dealing with this rolling quorum issue as unconstitutionally vague. And therefore, the Senate, the Senate was trying to address that provision in the Open Meetings Act in this session with Senate Bill 1640. It is, as Robert Browder and I have discussed, and some of the lawyers in my office, the language of the statute is not artfully drafted. It leaves a lot of questions in terms of the process that we had in place, that many public bodies across the state, and some of you know I represent all the school superintendents of the state and TASA, and so I'm well aware of this process of where governing bodies in budgets meet with staff, generally in either one-on-one or in less than a quorum, to be informed, as you should be. That's one of your basic fiduciary duties as an individual board member, is to be informed so that you can make informed decisions. And this, in my opinion, I think it addresses the issue here specifically because it was the budget, and all 11 of you are dealing with that same issue. I think out of a spirit of caution, we're hearing this across the state. Currently, the Kent County commissioners as well have done this. I had occasion to speak yesterday with Amanda and Dorothy and Zim about this issue because they had questions. Now, let me more importantly address what I don't think it blocks you doing, coming back to your basic fiduciary duty to be informed. I don't think there's anything in this statute as I read it that continues to not allow you to have one-on-one contact with the administration to get your questions answered. Where I think we have to be careful is where we have an organized effort on the part of the board to go through, like in the budget time. I think, and I mentioned this to Dorothy and Amanda as well as Zim yesterday, if you've got questions, you continue to write or call in on those individual issues that may come before you, as long as you're not discussing it with your fellow members. The way the process was set up here was very typical that I see across the state, counties and school districts and other public bodies in terms of the way that you are viewing your budget. So I don't think, as I said to the three yesterday, any one of you want to be the test case. So I think, Robert and I talked about this yesterday, Robert Early and I talked about this yesterday. I really believe that there's going to be an Attorney General's opinions that hopefully will give us some clarity, but there's a great deal of lack of clarity, and that really concerns me that puts you at risk. And so I'd be happy to answer any questions.
Yeah, Neil, I think that also goes and ties in with the snapshot I did some years ago that you brought to the board when we get an email.
Correct.
And I think maybe the board
Yeah,
needs to
yeah,
do that.
exactly, and that's a good point, Ralph, is that communications among board members outside of a posted board member meeting, and that means whether by telephone or by email, and where we began to run into issues in the past, if Ralph, to your question, if you asked, let's say, Robert, a question by email, but you copied your fellow board members, and then that series of emails going back, that's certainly going to be problematic, and that's a problem. If you got issues, you deal one-on-one with Robert and his staff. You don't copy your other members. You've got to be very cautious that anything that appears or even appears to look like a deliberation between more than one of you and your board that could lead to discussions related to something that's either on an agenda or potentially has. And there's not any issue that you don't discuss that couldn't potentially be on an agenda. So you have to be very cautious. And listen, if you get into some circumstances, if I've said this to you in the past, if you've got something comes up and you're not sure about, pick up the phone and call me. Let's talk about it. Okay?
Neil, I'm not sure that Roger Fisher heard that. Can you start
I'll
again?
bring Mr. Fisher. Mr. Fisher sits on another elected board, so he's probably aware of that. Go ahead.
If that's the case, when you are working on a budget, then would the organization have to look differently of how they're presenting the information? Because if you give me a top budget like this, there is no way that I won't need some information to understand it a little bit more.
That's a good question, Dorothy, and I think that's something you and Charlie and Robert and the rest of the board members need to discuss is what is a permissible format for you to become an informed member. And I'm telling you, it's in my response right now, based on what I see in this statute and what I don't understand about this statute because of lack of clarity, is I think you're going to have your budget discussions in a call meeting.
Yeah.
I don't see how you can get around it right now.
And would that mean that, well, it would help if you had more detail, then I wouldn't have to ask all the questions. I mean, that's kind of where the issue is that for a budget like this, there's always going to be some information, but if it was, I mean, I understand the top presentation, but there are some deep dives that you would need to be able to, I can't speak for anybody else, for me to approve a budget like this.
And I think going forward, and we'll use the budget as an example, Dorothy, and you and I discussed this a little bit yesterday, is I don't think there's absolutely anything wrong with you writing, in this case, Sharon Clark, outlining your questions. I talked to Sharon yesterday about this issue, that my advice to her, based on the lack of clarity in this bill right now, is her response needs to be in this public meeting so that all members of the board hear her response. So if you've got questions, and I advised Amanda yesterday and Zim as well, if you've got questions in advance of a meeting on a subject, there's nothing wrong with you reaching out on those answers. Don't copy your board members with your question. And I'm advising the staff, and Robert and I have talked about this, and I talked to Sharon about it yesterday. Their responses need, like, for instance, this budget, we know is going to be on this agenda. Those responses need to be in the open meeting, so, okay?
Neil, if I can just follow up on Dorothy's question. Dorothy, I was out of state and actually received an email from you, carbon copied to someone, obviously on staff, and, you and I didn't know what the law was. And so, again, getting the clarification, I got back in late last night, I think either two things, either when we get to the budget in the agenda day, either we answer, and staff should be able to answer those questions. If they shouldn't, the way that I'll check with general counsel, but it would appear to me that if we can't get those questions answered, we would call a special call meeting as quick as we can once it gets posted and it gets called for the entire board. And we would do it, and we would start at whatever time, 12 o'clock, and if it takes to whatever length it does when we leave there, again, as a board member, I want you to have your questions answered. I see that as the only remedy at this
Right
time,
now,
Neil, if we don't address it today. Go ahead, DT.
Well, Mr. Zimmerman asked me that question yesterday, and I said, Zim, you know the answer to that question. Absolutely no, they do not.
Is there a possibility to keep track of the question and then answer to the full board so that you don't have to spend time waiting for the next 10 days or something like that? We have a very short timing for budgeting.
Yeah, that's the problem.
And is there a law forbid the administration from sending all the answers to 11 board members from one person asking questions?
I think that's problematic under this current law.
Why, everybody have the same answer?
The way the statute's written, DT, you run the risk of being in violation of statute.
for giving everybody the same answer.
Answering the question to all.
Yeah.
To all,
In a public setting.
in a public setting.
Yes, Sim.
And then I have a second question, is that for me, as a common courtesy, every time I ask a question, I always copy a chairman and a vice chair, because I'm a board, I'm an officer.
I think that's a problem.
Yeah, that's, DT, I think that's
I think-
where,
I
I
think
received,
that's
I
a
received,
problem. My advice would be that you not do that.
Well,
I mean,
It's a common courtesy
I
to
know
advise the
that, I
board.
understand that, but unfortunately, that's the law we live under.
yeah, DT, I don't, we do communicate back and forth. That's, again, that's part of the board. Certainly not the intent to certainly violate anything.
And that- and let's
Hopefully
make-
we didn't, I don't think, but based upon the interpretation and now the law, we're all aware of it, because that's what happened during this process. I receive emails.
Yeah.
Because we're interested. And I appreciate the fact the board is interested, and those emails are going through to staff, because you're asking legitimate questions you need to ask. And then this came up, and it kind of, whoops. So that's why we're discussing this today. And if, when we get to the budget area, hopefully some of those questions you may have could be answered. If not, the only remedy I see, that's why I asked general counsel, I'll check with the board what they want to do, and I'll certainly check with Chair of Finance. But to me, that's the only remedy I see, because as you very well know, we're on a timeline for our budget, and it always comes down to this. You know, many of us on this board, I'm looking around some of the people on this board 8 to 10 years, this has been a budget process that comes down because we also have to meet the requirements of the Commissioners Court's budget, which is the county budget. So it's not just us saying, well, let's just address this next month. We are on a defined timeline. So again, we can discuss this more, Robert or Neil, unless anybody has any questions.
One quick follow-up.
Zim, go ahead.
Based on that, we have two counsel here. Who's going to take the lead to get those clarification, and when can we expect?
In your case, me.
Yeah, general counsel for the board would be for the board, yes.
And when can I expect some kind of
When you hear it?
clarity?
Well, I don't think there's going to be clarification, DT, on this bill until there's an AG's opinion on it.
Yeah. I think so. Take
And
the
if not that, then it's going to be the next legislative session, or somebody gets indicted for violating the statute, and it goes back up, and the Court of Criminal Appeals gives us further clarification.
Should we consider?
And nobody wants to be that, nobody
We
wants to
took
be
the
that
posture we
mess
did.
case, so.
Well, you serve on the city council. I mean, y'all are dealing probably with the same issues.
Out there to challenge, should we consider challenging? Not challenging is put them on the record and to answer us?
Is there anyone challenging it right now?
No.
Zim, I think you've got some
TML has
information.
processed a suit against the state on this issue.
Yeah.
Okay. I just want to make sure that.
DT, that's why I want to go ahead and call on Zim. Didn't mean to interrupt you, but I knew Zim knew that, and there's other people beginning to challenge. We should get hopefully something back.
Yeah. I just want to make one other statement about when questions are answered and they are presented here, when you don't have an opportunity to really digest that information, you aren't helping. I mean, the reason you ask questions is so you have enough time to be able to look at it, really evaluate it. And so when you say, well, we're going to just answer those questions in the meeting, and most of mine are financial, it takes me a little time to look at that. So I think as we go through this process, we got to figure out how questions can be answered, but you have enough time to really evaluate and digest that information before I have to vote on something. That's all I have to say.
Point made, Dorothy.
Could not agree with you
I
more.
totally agree. I'm sorry, Ralph.
No, Zim.
Oh, Zim.
I understand that we've got this short timeline this year, and I understand some of the reason why this seems to be a perpetual shortage of time to do our thing. What I don't understand is why we can't make assumptions. Fort Worth City Council, for example, and I think Tarrant County probably does the same thing, we have a budget workshop, 2 days. Now, I don't think we need 2 days. But during that day, that the staff would be able to present to us the stuff Dorothy's talking about, like deep dive into the items, and we can see what the thinking is, what the specifics of the item are, instead of just getting we're going to do something on this as a line and then what we're going to see today. That would help everybody. And then you go back and validate that when you know that whether the assumptions were correct or not, and come back in, and that would alleviate a lot of the pressure that we have at this time of the year doing this kind of a process, so.
Point made, Jim, and I feel quite sure that next year that will be addressed by the chairman, finance chair, and the board. So there's plenty of time to get that done.
Yeah, I just want to just pick it back a little bit on what Zim said, is that I think it was under Trent's leadership as chair. We really have gone away from that one day, sit down. We came on a Saturday. Steve even wore his jeans that day. But we spent time, we heard staff, we heard, so we left here, we left here with at least a consensus of board approval.
Right.
And I think I know it's asking of everybody's time, but I think we just need to get back to that at some point.
And to that point, Zim and Pastor, we as staff are amenable to that at all times. We will always go the direction of what the chair, and in this case, finance chair, or either one wish to do. We're happy to do that. And we, with a budget like this, Dorothy, I couldn't echo your comments anymore. We want that. That's why we in the past have not only solicited that, but I think it's been quite helpful when we've had those discussions with you or anybody else, and we're happy to have them. This was quite a challenge for us because it's certainly not what we expected, nor did we want.
So may I? Go ahead.
Sorry. I just wanted to add, we've had some of these conversations in the Finance Committee meeting as well, and Sharon's been doing a great job of helping with some of those PowerPoints that she had. I've asked for those PowerPoints to be placed on the portal for us, for me especially, as reference material, because I knew this was coming. That never happened. And so we want to make sure that that doesn't happen in future, so that we have those PowerPoints that just kind of come up, and then they're not on our portal, that we have access to that information.
You bet. Thank you.
Steve, you noted that also.
Yes, quick question, if I may, to council about the 1640. Sharon and I have an agenda call before every finance committee just to review it and make sure we know what's on there. Are those no longer?
No, those are fine.
Those are fine.
That's part of the process. You've got to be able to develop your budget, absolutely. I mean,
And
not your budget, your agenda. Your agenda.
Okay, so an agenda call is acceptable.
That's perfectly.
Second question, if you're aware, are there any exemptions for legal advice? I mean, can we call you?
Oh, absolutely, anytime.
Okay.
No, anytime. Okay.
Okay.
All right.
Yeah, mine. There may have been some addition.
Right, it was the PowerPoints that weren't on the portal. I didn't get any of those.
Well,
Yeah.
We'll follow up on that,
Yeah.
Amanda. Yeah.
Okay, thank you.
Go ahead.
So
All right.
I
Anything else, Rob?
I appreciate Neil's explanation of that. Again, this was the statutes by which we live by, and until they are modified, changed, redirected, or they stay the same, we will subscribe to those guidelines that are put in front of us. So thank you for your tolerance. We, in this case, are the messenger, not the writer of the legislation. So thank you all for understanding that.
What's going to be our calendar now to meet Commissioners Court?
Well, what we've done, the Commissioners Court have asked us, we will be making our budget presentation before the Commissioners Court on the 20th. And to Dorothy's point, we will deal that the same way we dealt with this board. We will not have any briefings or any questions from them. We will be making our budget presentation before the court on the 20th. That's what their request has been, and their request has been not to have the preliminary meetings that we historically have done for the past 10 years. So they'll be hearing that. Now, they'll be sent the budget in advance, same way, but that same situation will exist with the court.
Robert, anything else?
That's actually all I have.
Good. That was good.
Mr. Chairman?
Yes, Rob.
Is it possible, I'd like to make a motion either way,
Okay.
that we adjourn our meeting in memory of El Paso
And Dayton.
Dayton. And then I got news this morning that they had another mass stabbing in Southern California.
Thank you. Appreciate that, Pastor. There was a mass stabbing in California,
do that.
is what the pastor has reported, so
End of the meeting.
we will adjourn the meeting in that honor.
Gotcha. Point well made. Item number 7 is Dr. Schrader.
So this feels completely misplaced because I'm bringing neither meeting, legislation, nor budgets.
Why, well,
To this board.
shoot, there's nothing then.
One matter of business that I did need to bring before the board. So last month, Dr. Scott Kaiser decided to step down as the chairman of the Department of Radiology after a long service to both his department and this network. As we've done before in the transition, we turn it over to the departments to nominate a new chair. In this instance, the Department of Radiology nominated Dr. Kurt Shoppe to assume the role of chairman of the department. Briefly, Dr. Shoppe's an amazing individual, had the chance to meet a tremendous amount of experience in utilization management and appropriateness of radiology studies, and on Tuesday was unanimously supported by the Medical Executive Committee. So with that, it is brought to this body for consideration of Dr. Kurt Shoppe as the chairman of the Department of Radiology.
I have a recommendation for that. I'd like to make that as a motion, Chet. You can't, but somebody can make a motion for that. Dorothy, I have a motion. Second by Dr. Weber. All those in favor say aye. Chet, thank you very much. Dr. Hosmer, we do not have an acclaim. All right. Chuck, there's not a direct, anything else from acclaim this month. Everything's fine there. Committee reports and action. Quality Committee. Dr. Weber?
There's a bunch of policies that are on, I don't know why I didn't get it. It's on the,
Consent.
Yeah.
it's under the consent agenda, and there were 3 presentations by Lauren Burnside, Rob Stevenson, and Michael Hochberg that were very, very good, and giving even more credence to how we are maturing as an organization. And then the last thing I would request, is there any way that the board can either get some pictures or a video of the event that took place at the zoo?
I think we have that.
No? It's a big no? Okay.
I wanted to see the Lion King reenactment.
I tried, that's it.
Sounds like
That's it for
there's no
me.
quality there, Chuck. All right. There's no action needed on that one. We then go to Planning Committee, and Trent, I know y'all, any update?
Yes, sir, we
Y'all
did.
have?
Thank you for, I think the entire board attended the planning committee. It was an important meeting. It allowed us to move forward with our recommendation to Commissioners Court concerning the bond election, the bond results, and how we're going to deploy those funds. So appreciate everyone's diligence in that.
Well, thank you to your leadership and that entire committee. They've been busy, so thank you very much.
Mr. Chairman, if I could, real quick, for, since we're in committee reports, Amanda, we'd like to make sure that we're working with you, because everything that's reported at a committee level, all those spreadsheets, all those PowerPoint presentations are all on the portal. So if we're missing those or we're not directing you in the proper way, we'll make sure that they are, because they are all on there. And unless we're missing it or there's something that's happening, we'll walk you through that. So after the meeting, we'll do that.
Okay.
And make sure. Thank you.
You have a question?
Yeah. I have a question in reference to the planning committee.
Yes. Trent?
I'm sorry, Ralph.
No problem. The
I wouldn't call it
motion
business.
that we passed and all of that in reference to the bond, I guess I should be asking Neil, if we can have a discussion on that. I don't know how to pull it from the agenda and close, based on what transpired at that meeting. Is that possible?
And I was not at one of my attorneys was at that meeting. My understanding, that vote was the vote of the board and not the planning committee. And so it was voted on at that time as a board vote. As far as today, there's nothing on the agenda that will allow us to discuss it even in executive session. Now, the next step is that once the minutes of they'll eventually then go to the county commissioners court.
What
But
they
there's
have
gonna be
done,
an
let me
interim step.
give you a bit of an update. When the planning committee met, it was posted as a full board and planning committee. You had 10 members of 11 there. So the action that was taken could consist of the same as a board meeting. Because it was a recommendation by this board to the court asked me last week if I would provide them a briefing on what took place in that and what that meant. So I've talked and counseled with Trent and Angie and Lou Mattingly and others about the action that you all took at that level, and I will brief the court on the 13th. That's our usual time to go before the court, and I will tell them the action that the board took.
Well, does that clarify any questions you have, Ralph? Just
No,
because
it
he's-
doesn't. I can comment now. I
Sure.
just didn't.
Sir?
Well, Dorothy and I are going to have to attend, we're scheduled to attend a meeting, I think it's next week, in reference to that. One of the questions, I shouldn't say question, I've gotten a lot of heat since that board meeting, raising the question of what we did and why we did what we did when we really don't have a plan for what we're going to do. And so, some kind of way, I wanted to discuss that in some kind of form or fashion.
We can put it back on planning.
We can
as an
put it back
agenda
on next
item.
planning
You wanna
agenda.
do that?
Right, I think,
that'd be the best place.
I mean,
Happy to
trust
do
me,
that.
I've gotten calls
Okay.
that we're trying to undermine the system, but we haven't rolled out a plan for the bond program, you know, so, by approving those.
For the whole program.
Right, by us approval for the 2 community health centers, we haven't identified a place, we haven't, you know, so how did you come up with that? And we haven't come up with a program for the bond program. So I just wanted to put that out there.
Sure. Oh, I think we can put it
I
back
think
on
that could be
planning and
very easily
elaborate
put
however
back.
we need to. Sure.
Yeah.
In planning is scheduled for,
I don't remember the next planning date.
date, Trent, we can look it
I
up.
don't know. I'm not sure that we have even planned it
On the agenda for the next planning.
September. We'll put one on September, for sure.
All right. All right, takes care of that one. Anything else for planning? Trent, Ralph, anything else?
No.
Okay, got you. Finance, even though the finance chair was absent, it was an excellent meeting, because I had to chair that one also in his absence too, again. But, yeah, it was a record time and all that good stuff. But anyway, it was the initial discussion of, it was the initial discussion of the budget, and really the process that we set up that obviously we didn't know we were going to run into some legal issues on, which obviously 1640 apparently kind of changed that philosophy. But I will say this about the budget, and obviously next year we'll have a complete off-site planning. We went back and kind of checked, I won't get these numbers correct, somebody make sure I'm right, but we went back over the process of the planning over the years, and last year's budgeting process was pretty much similar to this one. And we probably have had one of the closest to budget to actual, because so many things shift in this organization, and many on this board have served as finance chairs. And so again, whatever that process is, we want to make sure that we give everyone the opportunity to vet, answer any questions they want. But we've done some of those off years that we were way off because something changed in healthcare delivery, something changed from the federal government, all those assumptions that we make. And so I just want to point out, if you look at the budget, when Sharon gives the budget in comparison to where we are this year, I mean, we've had a good year based on a lot of assumptions. So again, it is a budgeting process. So again, I point out that finance kind of hit the special point of that. Steve, is there anything else you need to say about finance? If not, I will certainly say the finance. We had a good meeting and good attendance. I also will say thank you very much in the sense that if you've been coming to planning, had 10 out of 11. I didn't check finance, but I think we had 9 of 11. I mean, this board stays very active on these committees, and I appreciate the time allocation y'all give. But other than that, that's really all for number 9, which I'll go to number 10.
Mr. Chairman, that planning
Yes.
meeting is the 5th of September.
5th of September, September the 5th. All right, thank you very much, Trent. We'll have it fully posted on the agenda, and any questions that we need in regard to what transpired at that meeting will be covered at that time. The other item takes us to item number 10, which it appears, Robert, I'm just going to go ahead and take this. I mean, you can see what's before you. Approval for the appointment of Ms. Labby to represent Tarrant County Hospital District for the following TIFs. And y'all can see all of them listed there. If there's any discussion, Robert, you probably could entertain that. Obviously, Ms. Labby needs something else to do by serving on all those. Anyway, but if there's no discussion, I'd entertain a motion. I have a motion, Dr. Wepper. A second by Mr. Zimmerman. All those in favor say aye. Aye. Thank you very much. Which brings us now to item number 11, which is dealing with the 2020 fiscal year draft budget. And Sharon, I'd ask you to come up and start in this process. Thank you very much, Sharon. You and staff have done a lot to get us to this point in time, so I will be quiet a second.
A couple of comments that I would make before Sharon starts for the benefit of board members and audience members. I wanted to see if you're going to move that desk or crawl under it. I was, yeah. Thank you. Thank you for doing that. And Sharon, thank you for not crawling under the desk to get that. Couple things that I wanted to go over with you all. Zim, I know that we always want to get better to try to figure out how to do this. You're going to bring new elements to this with how you did it at the city level, and we're going to respect that and appreciate that. Dorothy, we're going to try to answer all your questions and deal with this as we deal with the budget as we have every year. Amanda, as you look at a new budget, a $1+ billion budget is cumbersome and challenging, and we want to try to do everything we possibly can to make that work. I wanted to make a couple of basic overviews about this budget. There is an operational improvement fund, and let me explain from my 60,000-foot view that operational improvement fund. For the first time in a while, we have the ability to have some resources to deal with the contingencies that we deal with every year. You all will remember that when we passed the budget for the last 2 years, we've gotten notice 2 to 3 weeks after we passed the budget of different formula funding coming out of the federal government, and we've lost anywhere between $5 and $10 million 1 week and 2 weeks after we passed a budget, and we had to begin to scramble. That operational improvement fund, and I apologize for the name, we didn't know what to call it. So we called it an operational improvement fund. Each one of you might come up with a better name. And if we had a contest, we would award you the winner of the best name for the operational improvement fund. But what it is basically is our ability to have an organic budget with what we know is going to happen. And one of those things that is a strong possibility is that formula funding changes. And you as board members are going to say, wait a second, we just voted on a budget and now you're coming and telling us we have a $10 million deficit? That fund will help deal with that. That fund is not money that we have to cut out of the program. We have it. It's just going to be used for contingency matters that are going to come up during what we know is going to happen. Another major area is to speak to Pastor Emerson's issue and the others, and that is the master facility plan. In light of the bond, we're going to have to make some decisions, and we're going to have to prepare for where we're heading in the bond. And some of those decisions are going to take some additional planning and some additional details that we're going to have to go through, you as a board and us as trying to figure out the development of those. You don't want to start right when you issue the first tranche of a bond. So some of that's going to be some planning money in some areas that we're going to use so that we can better educate and help you as board members, and you can make the decision as to which way we go. The other thing I want to let you all know is you all are looking in this budget at changes that we will be making in population health and trying to deal with the management of our connection program. I will tell you in healthcare, if you hear the term population health, or if you hear anything that you're going to be doing for that basic population, you're going to get a different definition on population health for anybody that you talk to. So what we need to do is figure out where that population health is for us and what it is. So what we've tried to do is we've tried to look into this budget at the beginnings of managing our connection program like we've never done before, and looking at what we do for the most vulnerable of our populations and their utilization and where we're going. So you're going to see that in this budget as well. The other thing is that fund was created because we asked staff, managers, directors, and everybody else to have no new expenses in their budget from last year. We have to begin to prepare for a bond, We've got to prepare for the intricacies that come with that bond. So we asked the staff not to include any new expenses. A lot of the situations that we know now, we can define the problem. You all can define the problem. If you look at our population, you can say, oh, population health, social determinants, this, and this. You can easily define the problem. The solution is a little more elusive. So what we want to do is put some things into place, and some of those answers are not readily available today, but they will be available in the next month or the next quarter or the second quarter, and we don't want to have to come back to you to make budget adjustments. We want to have that ability, and we will let, obviously, you know, we'll let the public know as we do that. That's part of that fund. Let me deal with another issue that is consuming and challenging, and that's a claim. The question that plagues you always as board members and would plague me as a board member is, why do you have a physician group that loses money? Why can't we have a physician group that makes money? The first thing that I would communicate to you is when you look at where we are in comparison to other hospital-based physician groups, and this is not touting a horn, it's not telling you how great we are, it's telling you that we're in the upper percentile of loss, which is a good category to be in, not the bad category, the good category. We lose less from our physicians in our physician group than 75% of like category physician-based, hospital-based physician groups. So to Zim Zimmerman, who's joining our board and seeing these numbers for the first time, you're going to see parentheses around a number and say, why are we losing those millions of dollars? Well, part of the reason is our payer mix and the limitations that we have. We take in all comers. So everybody comes to our clinics, we take in and we deal with. We don't have the ability to stratify our patient base. So we're going to deal with comorbidities and higher issues of acuity than a lot of other physician-based groups are going to deal with, and that's a challenge. We also don't have the ability to enhance certain parts and say, you know what, we're going to emphasize and create this with our physician group, and we're going to create a heart hospital aspect of this. It's more challenging for us, and so it is difficult for that to be the case. If we could buy those services, we would be spending a whole lot more than having our own physician group, because the overhead cost of going outside for those services would be far greater. And then you would have double parentheses around any number that we had if we hired out for another physician group. So we want to talk that through with you all and discuss that today. After I get done speaking, I'm going to ask Michael Hochberg to begin to go into a little bit more detail about that, because if I'm a board member, that's an angst for me too, and that is, how can you lose money in this physician group? The last thing I wanted to talk about, which is an overriding issue, again, I want to go back to population health and our connection population. I want to tell you that I think you as a board right now are in a historic place. We are now beginning to manage and putting into place the mechanisms to manage our connection population. It's the beginning of that journey. It's not the middle of it. It's not the end of it. We're starting to do that. One could argue, why didn't you do that 30 years ago? Why didn't you do it 20 years ago? I think the organization is maturing enough where we can now look at the 32,000 or 40,000 or 48,000 people that are in our connection and begin to manage them. I think we have a better system of delivery. I think we have a better system of our community clinics. I would argue, Dorothy, your years and your dedication at JPS, we didn't have a very integrated system. We tried, but we had clinics and we had a hospital, and most people saw JPS only as a hospital. We're trying desperately hard to have an integrated system. And as we have that integrated system, I think we get more sophisticated. And as we get more sophisticated, we're able to manage the population. I would have argued to you 8 years ago, we probably did not have the context by which we could manage that population as well as we can now. So we're going to begin that journey and begin to manage that. So what we're going to do is set a baseline. When asked the question, where are we going? Where's that connection population? How much is it costing? What are we doing? We're going to look into all that and create that baseline so that we have a comparison. This will be the first year that we'll have a strong baseline by which we can begin to commit to. And we're going to, in that process, identify the needs. And in that identification of the needs, it's the overall cost. What is the overall cost of a connection patient? Is there a typical connection patient? What are we doing from a quality standpoint? What is the utilization? Is there a typical mainstream utilization of our connection patients? Do we have outliers? Do we have 20 people in a connection program that are costing the program 30% of its overall cost? That's what we will begin to vet out. So what I'd like to do, if you all don't mind, before Sharon starts, is I'd like to bring Michael Hochberg up and let Michael go into a little bit of a deeper dive just on the acclaim portion and that pounding question of why does a physician group lose money? So Michael, if you would come on up, I would appreciate that. And then we'll turn it over to Sharon and let her go through some of her remarks. Thank you all for tolerating me on that.
I'm not used to the front row, so it took me a much shorter time to get up here this time. So when Robert asked me to speak a little bit about why Acclaim loses money, I wanted to couch it in a couple of different ways. To talk about briefly, why do hospitals employ physician groups? Why do hospital groups as a general entity lose money? And then how do we ultimately compare to that? So when you look at why hospitals employ groups, and this is not a JPS trend, this is the nationwide trend of healthcare systems, whether you're the Cleveland Clinic, whether you are Texas Health, whether you are an HCA hospital or a Baylor hospital, they all are employing physicians, and they do so because of the ability to create alignment, coordination, and collaboration of services, so that you eventually get to economies of scale, you eventually get to efficiencies, and you eventually have coordination where across the board, your physicians are working in concert with those operational partners, with nursing, to deliver cost-efficient, high quality of care. And that is the main primary goal that all hospital-employed physician groups and why hospitals are employing physicians in record numbers. Now, the reason why hospitals groups employed or healthcare system employed groups lose money is a variety of reasons. And the first thing to think about when you look at it is, how do private practice groups operate? Private practice groups can restrict their payer mix. So that's why a number of private practice groups do not take Medicaid. They restrict on self-pay. They will only get commercial payers. Hospital groups will take all comers, and particularly for an organization like JPS, in our payer mix, it is heavily weighted towards uninsured or self-pay or managed Medicaid or managed Medicare, which traditionally are going to bring in much less revenue than a commercial payer. Additionally, hospital groups or healthcare systems are beholden to several rules and regulations at the federal level, in particular in Stark rules and anti-kickback regulations, which in a very basic nutshell effectively mean that as a hospital or healthcare system, you have to pay your physicians at a fair market value, which is based upon national benchmarks. You can't pay them based upon volume, but you can certainly pay it based upon productivity, which can be translated to be work RVUs, and those work RVUs are blind to the payer. So it doesn't matter whether it is a commercial payer, whether it's Medicaid, whether it is Medicaid, that physician is going to get paid for that level of service regardless of the payer. And those fair market values we have to abide by, and we are obligated to, are beholden to. Private practice groups are not necessarily beholden to those because they operate at a different level based upon, again, that restriction of their types of payers that they can bring into their private practice. And so for those reasons, all hospital groups lose money. And when you look at it from the MGMA benchmark, which is made up of hundreds of hospitals of employed groups, the 75th percentile loss per provider is $56,000. The median is $134,000. Ours, for the fiscal year 20 budget, is going to be at $54,000. So 75% of groups lose more money than we do, which means that we have done a very, very good job on not just managing our costs, but also ensuring that we've got alignment of our physicians, that we're abiding by those fair market value rules, and that ultimately begins to drive towards quality and enhanced care for our patient population.
Question for you.
Sure.
We have to be very careful when we say that, because when you form the group, the idea is to control the clinical volume, also better perform under capitated environment. So what are we doing to go there? Because the cost side of it, the loss side of it, probably we have to be careful because we have insurance that we receive payment from, but also we act on behalf of the county to pay for JPS connection. So to me, until I can see more utilization, the reason we lost less could assume to be we don't provide enough care. So I'm not saying anything, I don't know, but just want to make sure that we put that in perspective as we go forward, because I've been asking for cost of care for the JPS population connection for a long time, and we still don't know. But you know, I appreciate the explanation. Most hospitals, you're right, I mean, they lose a lot. Some up to 196,000 a year, that's on the high side. But they have a plan to switch that to value-based, and would love to understand more how we do strategically to come out of that, because under the new Department of Health and Human Services Secretary, the facility neutrality law affecting getting high reimbursement as a physician employee inside the hospital to stir competition. So we may be getting some challenge, a lot of pressure going out in the out years. So just want to make sure that we keep an eye on that ball.
Yeah, so you're absolutely correct. It touches upon exactly what Robert said in terms of our focus on that connection population, looking at our utilization, understand what our variation in care is, all of which will eventually drive towards improvement on cost, improvement on utilization. But when we look at the loss per provider by itself, it's blind to that utilization piece, right? Because the heaviest weight is really relative to salaries and the revenue that comes into it. The other side of it is we're looking at a claim as just really one half of the equation, right? The real equation is the physician group, hospital services, and how that looks in the all-in on the network side. And so those are all the elements that you're absolutely correct. As we become much more robust in the cost accounting system, in developing that population health software, and understanding what those episodes of care look like from a capitation and fee-for-value perspective, will enable us to be that much more efficient in delivering high level of care at lower cost.
Yeah. That's why I'm very interested in seeing going forward, because when the patient shows up and if they can't get access to specialists, we can save a lot of money, but we're not doing them any favor, or it takes too long for them to go see a specialist, or they're hanging on to the patient longer than they should before they go to a specialist. All that contribute to cost. So that's why I said be careful when we say we lost less, because our mission is different. But I'm pretty sure we don't have any data, so we can't talk about it. But I can feel that you guys provide great care. Don't get me wrong. I just want to see more information to support.
As we develop the population health piece, you are correct, right? It's understanding from an evidence-based standpoint, when is it appropriate to refer to specialists? Are we overutilizing that piece? Are we underutilizing that piece? And so that will give us that much greater amount of information to guide us in the future state as to what services, what do we grow, what does our community really, truly need?
Yeah, I'm one of the few that's not concerned about the loss of the physician side. For me, the system makes money. It's just how do we look at the whole system rather than the hospital and the physician. So I'm not one of those that are concerned about that number. I'm more concerned about the utilization, all that stuff behind the scene, which we can't get to at this point.
Yep.
How far along are you in the cost accounting system? I mean, is it already implemented? You're already getting data now? I mean, you mentioned the cost
I'll turn
accounting.
that to Sharon.
So we have got all of the hospital information into cost accounting. What we don't have, we're still trying to figure out how to integrate. There's a large component of the outpatient pharmacy costs that we have not gotten in yet. We're also working on bringing the physician services and costing for a claim to get all of that in. Medical center costs, we've got all the RVU development in, and we are able to look at patient level, but we still don't have some of the bigger components that are outside of Epic. We're working on bringing those in.
This is like a broken record. I think you guys look at the wrong place. You look at Epic, if the patient's outside Epic, you can't see it. I think from a JPS connection standpoint, if I'm not mistaken, you guys using the TriZetto system. The TriZetto system is the payment system to reimburse every aspects that deal with JPS connection. Why not look at from there?
We have pulled in that system and developed a way to bring all of the professional fees that are going through our outside medical services department into cost accounting. So that's part of the hospital cost. And that whole payment system only captures what we pay for the professional component to the physicians that see our patients. It doesn't include the inpatient cost. It doesn't include the cost that would be for pharmacy. And so we're working on widening that out and making sure that we have the whole picture.
You should be able to bind the data from the inpatient.
We are importing that data into cost accounting at a patient level.
I think you guys are looking at such a big project. I think for us, we're looking at JPS connection. We should have a data all around, a 360 view of that patient itself.
And DT, part of what you're going to kind of hear throughout this budget, both on the medical center side and on the Acclaim presentation, is that we are looking at the software that will help us integrate all of the clinical information as well for that population. We're going to focus on connection first, and then I think we can expand it into other areas.
I think we're looking at two different things. You should be able to pull all the information that you need on the JPS connection. You should be able to pull all the information on connection patient through the TriZetto system. And then you can analyze the cost of drug. You can analyze inside, outside, through through a script or whatever the PBM side that you guys are using. And then most of them are 340B anyway. You should have a report back from the 340B to analyze the cost of care. It doesn't have to be precise, but at least you know where they are to see if do we have enough network adequacy? Do we have enough specialists to support that population we have? It's good if we go outside and pay out the network, because at least they have the care until we can afford to recruit a doctor and all that stuff. I think it's very important to lay out how things are done, but it doesn't have to have one perfect system sitting out there looking at it. I mean, I run a business. If I can't get it, I'll get paper and a calculator. I'll calculate it myself. But that's for another day. But we need to get there soon. Otherwise, we can never move into value-based.
So, but again, you will see in this budget, right, because cost accounting is one piece of it, right, which is Sharon and her team are working on all those elements there. Then the other piece, though, is marrying that information to the clinical aspect of care. And so once we have that element, which is part of what's in this budget, is to create that platform where we can marry those elements together, then we're going to have a much greater ability and transparency to manage that connection population, demonstrate our success in that, and then be able to translate that to all our other populations that come through the door. And so there is a very significant focus on this budget exactly to that point, so that we're able to pull from various different platforms and marry that information together.
I guess I hear you say that, but I've heard we bought 3 different systems to help us get that same information. We brought in one that we sit here and discussed and said that was going to be the answer. Epic was going to be the answer. And we are 5 years down this road, or a little bit longer, and we are still pulling that together. And we have invested many, many dollars into that IT system. And I guess we ought to be able to get a little bit more out of that IT system with all the investments that we've made. I can't think of all of the system that we put in place that was going to be able to drive it down to the provider level. Then we brought in another system that was going to merge that. And so, to me, I hear this, we are going to. And where I would like to see is now, what is the date? When is this timeline? Because I can't go with more, we're moving there, but I don't have an idea when that date is going to be. Okay.
Point made. Anything else, Dorothy?
That's all I have.
Yeah, I have, Dr.
You had a comment,
Dr.
Ralph.
Hoxenberg, is the data that you gave about the different hospitals and around the country that's losing, is that data accessible at some spot, or where did you gather that from? How do we?
So it's called from MGMA, and so MGMA is a national benchmark. They do surveys.
Michael, it's called Medical Group Management.
Yep. They do surveys of all the hospitals. They do surveys of salaries, and we can get you that specific information if you want it from a drill down.
It provides all that information.
It has it.
I'm gonna ask Steve to read it and then I'll.
He'll be totally up to speed on that. Question for Dr. Hoxberg.
Two is, our population, we have 42,000 enrolled members on the JPS connection. How many I just want to see what's the risks that we're taking on. How many of them are complex cases? How many of them are high cost? How many of them are rising costs that we should be predicting? And how many are healthy? And then how many are having diabetic, but they are also pregnant, that may go away afterward, or the one that will, so we can see the progression, the disease progression, so that we can calculate and all that stuff. And we are so far behind from other systems today. That's why I got a little bit frustrated, because I think, you know where I'm going. I'm not criticizing the physician group at all. I just say we just need more dashboards toward that, so that you guys know where you guys going, because
Right.
you guys working very
You drive
hard.
care towards it, absolutely.
I
From
just wanna
case
wa-
management to physicians to the network. Correct.
I have a
Anything
quick
else?
question for you.
Go ahead, Dr. Sims.
The revenue that gets accredited to a claim for the outlying clinics, is that the professional component only, or does that include the facility revenue?
For a claim, it's usually just the professional component. There are 2 clinics that are owned by a claim, that's orthopedics at Ben Hogan, and there is a women's clinic at Clabsaba. So those are the 2 that there's a minimal amount of facility revenue.
So
in a
those are not
claim.
run as provider-based clinics like the others are? Those are run
Correct.
differently?
That's correct.
Any other comments?
Steve, anything else?
that you have?
Michael, anything else?
I'm good.
Thank you very much.
Thank you.
Sharon, before we start item number 11, we started this board meeting today talking about both in-house and general counsel for the board, SB 1640, most of which us on this board were not all that familiar with until that legal definition. We've also brought about the question is, I had to ask general counsel, is it okay for me to talk to the vice chair and the chair of finance? Because we in no way wanted to violate any laws. You know, I said, as chair of the board, we have a job to do and responsibility to run the hospital district is the board of managers. So I've asked both the vice chair and the chair of finance, I don't want any director or board member to be making decisions where they feel they do not have adequate information. Based on the conversations I've had, we like to start the budgeting process, and during that process, if we reach an impasse that we feel like is not going to get us to a point in time that we can truly say we understand the budget, I'd entertain a motion that we would call a special meeting, and that special meeting would have to be Monday, Tuesday, or probably Wednesday of next week, and we will set the times. I know everybody has busy schedules if we get to that. So it is our intent to be able to answer those questions, both with Sharon and staff, as we proceed through the rest of the afternoon. So I would tell any visitors, they're certainly welcome to stay and hear this process, but it could possibly get lengthy. So, and again, thank you very much. I'll bring this point. Sharon, I will turn over to you to start on item number 11. And like I say, if we run anything, I'd certainly entertain a motion. Sharon?
Okay. So I assume that a lot of you, based on some of the questions that you were able to get to me, have had a chance to read through this. I'm not going to read the presentation to you, but I am going to try to pick out some highlights as we go through each line item. So I know there's a couple of new board members, but hopefully for the rest of you, this was a familiar format and you were able to follow along for the most part. Robert's done a really good job about talking about some of the highlights that we've had. I'm going to flash the combined income statement up on the screen, and then we're going to go through separately the network, Acclaim, and the foundation, and then we're going to come back to the total column. So I guess here I just want to point out, when we start the budget process, it's always difficult to determine how did you get there? What was your target? You can't start a budget process without a target, because if you don't know where you're going, then things creep in. Robert's already talked about the fact that we did it differently this year. We asked all of the directors to hold constant. The only thing that made it into the first run of the budget was things that we were obligated. So we did have new expenses. We had already started new programming, but if the contract was not signed at that point in time, we sat down and reevaluated things, trying to make sure that we had some planning dollars in our budget that would give us the flexibility that in prior years we have not had. So when you look at this as we run through the medical center ended up, let me see, I'm losing my touch here. The medical center ended up with 38.9 million as an operating margin, and the bottom line, which includes all of our interest earnings. That's about a 3.5% operating margin for the medical center. You can see a claim at 26 million. We have the foundation that is producing close to $1 million. And so our overall operating margin is about 1% or 13.7. When I started to create a target, you do have to ask yourself, what's the goal over not just this next year, but 2, 3, 4 years? We all have been talking about in this meeting the anticipated issuance within the next 18 to 24 months, most likely, of that first tranche of debt. The principal and interest payment on that debt is estimated to be right around $12 million. So even though we did not budget for interest expense this year, my goal was to allow us to be able to budget for that 12 million. And that is why you see back here, when you add up these two amounts, it comes to the 12.8 million. So if we were to, when we present at Commissioners Court and JPS is asked the question, what are you gonna do when it comes to the point in time to issue debt? We can say, well, we've already allowed for it. And that 12 million, the 12.8 is sitting as my operating margin. So it's not a break even. We've actually produced enough to pay for that debt service.
Can I ask a question, Sharon?
Yes.
Tell me how that relates to the reduction in the INS portion of the tax rate, because it looks like we've actually reduced INS and increased O&M. So how does that mesh with that?
So it doesn't mesh with that at all right now, because we haven't incurred any additional, and I'll talk about, if we can wait until we pull up
sure.
that really complicated tax slide, I can bring everybody else up to speed on how that breaks out. I'm not anticipating that breakout to change this year. You bet. So moving on into just the medical center itself, we have the highlights, which I hope you've read. We did get a large increase this year to our tax base. We have also, we're getting ready to open up about 26 new treatment spaces in our emergency department, which is vastly needed. If you remember, we just opened a new oncology and infusion center location. We also are going to focus on the ever-important rev cycle. We need to really collect what dollars we can for the work that we're doing. Population health, we've already spent quite a bit of time on with the conversation earlier. The utilization and coordination of care, both our inpatients, and that kind of rolls into the JPS connection population. So even before they come in to our doors, how do you start to manage some of that care? We're looking and trying to develop new ways of our referral process and just how any patient accesses care at JPS. How do they get in the door? How do we get them to a primary or specialist? The electronic medical record support is always a large cost in our budget, and there's a lot of efficiencies that we can still realize through that electronic medical record. We have a specialty pharmacy that is going to be new, where we can actually dispense some of those high-cost drugs to our patients. So that will help capture reduce that expense, as well as some of the profitability from our commercial patients. And supply chain improvements, we are going to look at that. I think we've budgeted about $4 million, both in purchase service and medical supply expense, by looking at sourcing and contracting. So you've already seen the total number. We talked about this 38 million earlier, and I just wanted to kind of roll forward our baseline budget where we ended up. This includes all of the normal expenses, the inflation in both revenue and the expense. We also identified some expansion and growth that was going to be happening. This includes the ED that I talked about. We're opening up a third MRI in October. The oncology center is going to have a full year impact this year to the budget. We also have the 340B retail program that will be operational for a full year, and some physician services in this column. Some of the initiatives that we've identified is revenue cycle, and I'll talk about that more in detail, but we've added about $5 million net to our operating margin with some rev cycle focuses. The specialty pharmacy, we'll talk about as well. That comes in through net patient service revenue, and there's some expenses that are scattered throughout. The supply chain, $4 million, and the care management focus that we've included some additional care managers throughout the system. Oh, and I forgot the operational improvement fund. That is actually $22 million. It's a pool of dollars. It's not dollars that are yet to be identified. It is, the funds are there and budgeted for in our expenses, and as we bring ideas to fruition, they will likely come through finance and through planning committee for use of those dollars. Those dollars are not for small departmental improvements. These are pervasive new programs and new startups and facilities that might be impacting this next year's budget.
Sharon, before you leave that.
Yes.
When you were meeting with some of the directors and VPs, were they already recommending, suggesting some programs that if you had approved, that would have impacted those dollars, or you didn't have any coming from any of the directors?
No, there's always new expenses that are requested from directors.
No, that's not, I know directors ask for expenses, but you're saying initiatives, stuff that's going to change how we do things. Those usually come up from those other departments. So, did any of them have any ideas or proposals that you think might fit into that? I'm just having a problem understanding how I would propose 22 million and I don't have any idea what it's gonna be yet. Okay, when I said I'm having a problem with 22 million for initiatives, and I'm trying to figure out, give me one of those initiatives, I mean, I just can't believe that I need to put 22 million and I don't have any idea what one of those initiatives might be. That's all I'm saying.
I can give you a few ideas that we're not, these are not far enough along to actually have a concrete budget,
Right.
but will likely be accessed in that fund. Robert already mentioned the formula funding is always a concern. We don't get that until September. So there might be, that could be used as a contingency for any decrease in formula funding from either DSRIP, UC, or DISH.
Yeah, got that one.
We have been working, there's a work group that is in process right now about looking how patients identify where to call for JPS. How many points of entry do we have into the system? We don't have a fix around that yet. We're still looking at that. So hopefully within the next 3 to 4 months, we'll have a better answer. My bond issue costs, if we do move towards a bond issue towards the end of the year, those have to be expensed now per the accounting principles, and that will be close to $1 million. We've thrown around from a facility development standpoint. Reverend Emerson, you were talking about further conversations, but just as an example, if we were to open another medical home, right now the expenses that are out at the Northeast is close to $7 million. So if any part of that might or might not get operationalized, relocation of the PEC, how do we deal with the psych patients that are coming in the door right now? So those are some of the ideas that we have identified. We have not assessed a dollar value to any of those, maybe with the exception of the bond issue cost. The timing is still being developed. The further development of our population health strategy, once we get the data management is in the budget, But what comes out of that data management and those strategies to move forward have not, we don't have a skeleton of that yet. So that would be a great candidate for some of those funds. Does that help you?
That helps. But for the PEC, I know that was one of the 4 projects that we already talked about. So I'm assuming that if that was one of our priorities to do something, that would already be a part of the budget and not in that initiative.
So it's an initiative, but there's not likely going to be any operational costs associated with PEC for probably a good 9 months, right? It's going to have to be developed and rolled out. And again, you can't budget for it because we haven't gotten the skeleton drawn for it. And as those bigger projects develop, for the first time, we can set back as an executive team and say, okay, instead of looking on how in the world will we pay for the growth, we've actually got some funds set aside that we can utilize.
Dorothy, if I could just say one comment here, and again, I think your point's made, it's $22 million. I think I want to make sure, because I had, with finance background, obviously I had this kind of same question, Steve. That $22 million is not earmarked for any particular function at this point in time. And as Ralph and I were talking, if the board even has an idea, they want to suggest for those dollars until we know what we're going to happen to us with regulatory revenue coming in. That's always an issue this board has to deal with. I think the question is, finance will monitor that $22 million. It's not that it's just a fund sitting out there that you can go in and subsidize your budget with or whatever. I mean, that was the intent, Dorothy, of when I first saw that, and Steve, you and I kind of first talked. I want to make it perfectly clear, it's just not $22 million. It is a specified fund that we would have to go into, and the board would see it. Those issues would come back through finance. Robert, is that the way? I'll make sure I don't say something here that's not, but that was the reason behind it, Dorothy. I don't think right now there's any specific issue for it, but it's just not a fund that out there in June we're short someplace. We say, well, let's pull $5 million out of there.
To Sharon's point, we don't know the specific line item that would be, but we know those initiatives are going to be coming. Yeah. And what we have done is when we get the $5 to $10 million hit from the federal government, we have scrambled. And then we've gone back and told departments, you don't get the money you thought you had in the budget because we're now at $10 million less than what we were. This gives us, for the first time that I'm aware of, the ability to not only cushion that blow, but we know as we start the bond program and others, we are going to have initiatives. We're just being very transparent with you as board members and telling you that money is there. We just now have to define where it's going to go, but we know it's going somewhere to either one of the 5 areas that Sharon just outlined or other areas that will come up during the year.
I believe, Dorothy, we did talk about one time about just adjusting the budget. I believe that came up, Ralph, correct me, back when we got hit $10 million 2 years ago when the federal government pulled back on our funding. Budget had already been approved. We got hit $10 million. We had to take it to $830,000 a month. We had to start looking at where you cut because we didn't have the revenue. I think where I believe this to be is based upon these funds are there. And the budget, this board would see how those dollars got reallocated and how they were used. Is that not? Anyway.
And we'll know a lot in October, right?
Yeah, when October gets here.
Numbers
Late
are.
September.
That's good, in September. And we're talking about 2%, right?
Talking about 2% of the total revenue of the district.
Squirrel it aside until we know exactly where it needs to go.
But this board and finance will see where those dollars are expended. Yes.
I'm going to say this, and I don't mean to hurt anybody's feelings, but I believe if we had a strategic plan that we was targeted toward, I would feel a little bit better. Instead of just saying, well, we might, that we know, and the one that I'm comfortable with is I know we have changes in the UC and all of that. But as a large organization, we should be sitting here with a strategic plan saying, this is where we're targeted to go. This is where we're going. Right now, well, we're just thinking about it. I'd like to see that plan. The milestones, the strategies that we're going to do for the next 5 years. I mean, it might change, but For a few years, we knew where we were going for the next 5 years. After that, we've just been, well, this might be a task. I'm just thinking that we're too large for that.
Well made. At the same time, the district's very strong. We just passed $800 million bond package. So there's a lot of good things. The time to do that strategic plan now, we're on the other side of a bond package. As you know, we were committed for the last probably 2.5 years. We're at a perfect time to do that, and that will certainly get done.
That would help for us to know long-term.
Got you covered.
Is there a level of expenditure out of that fund that requires board approval once it's passed?
Steve, I'm unaware of a limit. Anything that comes out there would go back through finance.
Contracts
Go
greater
back,
than
yeah.
half a million.
Yes, finance got to approve it.
Anything, Robert has up to $500,000 authority, anything else has to go through finance.
Has to go through.
Goes anyway.
That's
Yes.
correct. That's,
Over $500,000.
$500,000.
yes, sir.
I've already confessed that I'm not a financial expert in I'm barely able to balance a checkbook, but the computer's helped me greatly. But you say that 22 million, we've got that 22 million available. Where is it sitting right now, and is it identified in the available category as that 22 million?
So I'm gonna try to kind of give you an accounting answer to that. Where is it sitting? We kind of looked in kind of the things that I've talked to Dorothy about when I was trying to answer her question about what could you potentially use it for. I spread it between several categories as I thought about population health and some of the other issues that we have going on. It may or may not be utilized in professional fees. We might not have any need for additional medical supplies as we look through the population health strategy. So the way that I spread that is it's sitting in logistically a separate department on my books that no one has control over or can access without Robert or my approval. Is that your question?
I think so.
Okay.
So somewhere in the revenue side, it exists, but it's not set aside as a line item in revenue that you're
No,
tracking.
and it's actually setting on the expense side, kind of at the bottom of the income statement.
Okay.
Good question for a guy who said he can't balance his budget. I think he did really well.
And I'm glad we're talking about the deposit side of $22 million, because this board's discussed some tough decisions in the last few years. We've been on the flip side where we got amounts as much as $500,000 we had issues. So again, it's kind of a good thing where the district is to have this availability. It has controls around it that finance and the board will deal with. So it's, again, as a district, it appears to be funds that could be utilized the right way going forward. But again, point well made. Go ahead, Mr. Chairman.
Quick question, Mr. Chairman.
Yes.
So, I guess I'm in the Zoom School of Finance.
Now we've elevated it to a school. At first it was a confession, now it's a school. Go ahead.
You are both Aggies, I could say that. Anyway, all right.
Exactly.
I want to make that point perfectly
Oh,
clear.
yeah.
Yeah, they are both Aggies.
Where did we find $22 million?
So, again, when we started at the beginning, we were very disciplined with our baseline and said, you know what, we're not going to let, $200, $500 million creep in for small projects. We really want to pool the resource and try to figure out how to make substantial change with it during 2020. So we did not do a normal budget where we come and we try to cut back down to a target. We were really careful when we turned in our baseline, that it was truly a baseline. We stay the same. We didn't add, requested FTEs. We were very tight with those as well. And when we got to the end, we had the 22 million, and we could have gone back through and looked through the pages and pages of departmental requests that got turned in and allocated that 22 million. But we also know that there are some really big projects that are coming up and we needed the ability to be able to act really quickly and still financially responsible. So those funds were left intact. Does that answer your question?
Isn't that what you were asking? You said plans, directions made abroad. Give me an example.
Well, yeah, I mean,
You just said that, Sharon, there are some plans.
well, she told me that they had some plans, but,
I agree. Give me an example.
Can we get some
So,
assurance that, usually that's a contingency plan type thing, but I just want to make sure that we don't take the selfishness, because that also tied to the performance, that tied to bonuses and performance. And this is for the future, that to be spent wisely. And are people not deliberately not spending so that we can hit that number?
Sure.
From
I mean,
the bonus part. I just want to make sure that we keep it
Okay.
above board.
I think that's a fair trust factor. Yeah,
To
detail.
keep the honest system in place.
And again, the way I look at it, it's 2%. Most projects, all even have a contingency fee. You could have spread $22 million across a $1.2 billion budget in the operational side. We're awful good around this table, but it's been very hard to find those numbers. I think this way, if those dollars are spent, there is an approval process in place, and finance approves, and this board will see where those dollars are spent. We could have allocated them within the budget, if that's how it had been, and whether it was spent or not spent, all the board would have seen monthly is whether you were on a line item somewhere in that massive budget. This way, those dollars are set aside so you know where they're going. I dare say $22 million could have got spread across that budget and operations pretty easy. So again, very good question.
one other point I just want to make before we leave this page. I feel like my job is not to produce an annual budget. My job is to make sure that the 2021 budget goes well, the 2022, 23. And if we don't start to plan today for the bond package, regardless of what gets into that first wave, we will not be able to operationalize from an expense structure, even though we can pay the principal and the interest, we would not be able to turn those projects on and still have a strong financial picture if we don't start planning for that today. We're not going to be able to bring 4 projects on without those expenses hitting. So this is the plan, not just for an annual budget, but to make sure when those projects do get operationalized, that we can afford to do it.
Sharon, wouldn't one way to sort of illustrate whenever these funds are being used would be to identify on your backup sheets, that on your sources and uses of funds for your backup for agenda items? Wouldn't you say that that would be coming from the operational improvement fund if those were specified funds?
Yes.
Because
I need to answer
that
question,
then,
Trent. Yes, that's the way.
that would be how I would be looking for, in other words, if I saw dollars that were being spent that were not identified as this, I'm assuming that's general fund expenditures.
Correct.
This is gonna tell me that this is operational improvement fund, and I'm gonna be able to trace it directly back to these numbers, right?
Correct.
Okay.
And new initiatives that have not.
What Trent just raised and what Dorothy just said, and I hate to be a broken record, but and what you just said, Sharon, about what we're receiving today and looking long range, what we expect, it's just, and I'm uncomfortable until we as a board somewhere get together and set direction. I think we're then doing day-to-day budget, and we should not be doing. My growing up in municipal government, I always taught the budget is really a guide. It's not the actual how you operate. But if we don't set some direction and guidance for JPS, and there are experts that understand the trends and where we're going to go sitting in this audience. And we need those experts to talk to us about what's they see, what's coming in the near future. So as we talk about budget, we can now start putting pieces together. And we talk about this 22 million, but we have no idea what's coming up the road. But there's individuals in this audience that do, and I think somewhere we as a board need to just take a few minutes, a day, an hour or something, and talk about where we're headed.
The audience just nominated you Board Member of the Year. Everybody's head popped up and said, we are indeed experts, so thank you. You've won.
And Sharon, the 12 million for a possible bond issuance is out of that 22, or it's a lot?
Yeah, so, no, it's not. It's down here, I'm sorry, let me go back a minute.
That's what I.
Let me go back to the combined. So when I talk about the 22, it's actually sitting right here. I did not budget it. If we were to, so this combined is like 12.8 million, all right? If we actually had the bond issue planned, my expenses, there would be another 12 million of expenses. And this number would be like 800,000, okay? So it's embedded here so that we can say as an organization that we are ready when the time comes to be able to pay both the principal and the interest payment on that debt.
That 12.8 is separate from the 22.
It is, yes.
Yeah, they're not gonna issue $200 million in bonds that we can't show we paid.
Okay, so.
Page 2.
Yeah, we're on page 9. Somebody order pizza. All right.
Out of your
here all
own
night.
pocket.
Yeah.
So one of you experts.
So hopefully these slides will pick up a bit, but I'm going to go through some of the stats. Those are really important because that's what drives our operational budget. Our admissions and our patient days are going to remain relatively constant. We are very close to capacity. Urgent care, we're expecting a small increase, and I wanted to spend a little bit of time on the emergency department visits. They are increasing 5%, and there's 2 drivers to this. If you recall, we've had a change in the way that our behavioral health needs enter the facility. Instead of going directly to the PEC, they now go, all walk-ins go to our medical emergency department. So that's accounting for about 35 a day that are going into our emergency department versus the PEC. And you'll see a corresponding decline on the psych emergency center coming up here on the next couple of slides. The other thing that's impacting that increase, we are really busy down there, but we're going to have 24 additional treatment areas. And so we've also made the assumption that not necessarily more people will come, but less people will leave without being seen. That has crept up to about 4%. We're taking it back down to kind of a historic 2%. Our inpatient and outpatient surgeries, we're remaining pretty level between 19 and 20. And our primary and specialty care visits, you can see primary care, we have raised those. That's equivalent to about 9,000 cases for primary care. And for specialty care, that's just under 3,700 visits.
Sharon, on that, with the primary care and the specialty care, do you have a specific payer mix for those? Yes. For the primary and specialty care, is there a specific payer mix just for those? We see the payer mix of the entire hospital, but for those 2 specific items, do we see what
Interestingly enough, it is almost identical to the overall payer mix. The only difference is the split between the unfunded. The connection makes up about 30% versus the overall 20%, and then we have another 10% self-pay. So it's still 40% unfunded, but it's much more heavily weighted in that category towards the connection population, which makes sense because they're seeking primary and specialty services. So for admissions and patient days, this page relates back to behavioral health. So the next two slides are specific to our mental health. We're not expecting more admissions. Again, we are very full all the time, and therefore our patient days are relatively unchanged as well. And as we discussed earlier, the PEC visits are falling because we see them going to the medical ED versus the PEC. So that's a lot of acronyms right there. We do account partial hospitalization. It is, I'm not going to cover all of our statistics, but the PHP remained fairly unchanged from the current levels. You bet. And you can see that the psych clinic visits, that's about another 1,800 that are a little bit down from 19 as well. We are down 2 providers, which is one reason for that slight decrease. And then we've also got a couple of planned maternity leaves during that time. So we've tried to account for those providers being out. So as you go into revenues, this is always a good slide. It seems to be a crowd favorite. Our patient revenue makes up about 42%. Our ad valorem taxes make up an equivalent amount. We have our supplemental funding, which if you looked at this chart 5 years ago, that number was closer to 15 to 16% for supplemental funding. As Robert mentioned in his opening remarks, those tend to go down every year for us. And then we have a small portion of grants, the tobacco fund revenue, and other non-patient sources. Our payer mix, Amanda was asking about that. What I call unfunded is really our connection population as well as our self-pay. So that's about 40% of our pie. We do have commercial plans at about 15%, but as a reminder, a large majority of those plans do have high deductible and copay amounts. We do have our Medicare and the Medicaid population. And we've not made any large assumptions on any changes for that. When you take all those volumes and you look what's going to happen to our net patient revenue, we're actually expecting about a 5% increase. I've mentioned, but this revenue cycle initiative, it's going to add about $6.2 million. Rory McCready, my partner in crime, the VP for RevCycle, is responsible for the $6.2 million and producing that, so no pressure. But it's things that we've been working on, and we think we've got some traction. Now, it's a net of $5 million. There are about $1.2 million worth of expenses that are scattered throughout the budget for that you'll hear about later. But it's really denial management, case mix documentation, charge capture, just focusing in on further collections. And we do have some managed care contracting that had a positive impact this year as well. Yes, I think it does. And the volume increases, those are kind of new services that have rolled on that we didn't have last year or didn't have the full year impact for. So that's going to produce about another $5 million for the emergency department, the third MRI. We did with a cancer center move, we were able to add a second linear accelerator and upgrade the old one. So we have 2 functional at that location, and the specialty pharmacy. We do have an annual price increase to our charge master that is contractually allowed from that 15% commercial payer mix, and we're able to realize about $5 million from that. And you can read through the others. We did get a small increase in the Medicare-based payment rate for inpatient. This 3.8 is also kind of a continuation of improved rev cycle efforts. We have focused on that pretty heavily for about the last 2 to 3 years, and some of those past efforts have increased our collection rate in the current year. Our tax revenue, which is about 40% of our total, you can see that we're expecting about $462 million from our ad valorem assessment this year. There were some large increases in the appraised value. The largest of those was in the commercial. The commercial real estate went up by 16.6% in the county. And this is taxable value, the real estate assessment. We also had an increase in real estate residential. Much of that was new, but they don't break those two separately. That was an 11% increase. Industrial was 12%, and agricultural properties, although it was not a huge amount, was about 20%. So the total value in Tarrant County, the appraised values went up by just over 11% this year.
Sharon?
Yes.
Based on what the state legislature did this year, do we see this year or coming years where we'll see a plus or minus impact on our ad valorem tax revenue?
So that's a great question, and what the legislature did how would it affect us in the future years? We were actually exempt from the lower cap on the effective rate as a public hospital. The effective rate this year ended up being 6.23% for us, which is well under our legislative cap of 8%. But if that law would have gone into effect, it would be a very different budget year for us. It's a great question.
Sharon, I think to Ralph's point, the other piece of that becomes overall ad valorem revenue generated to the hospital, notwithstanding our own cap, but what others will be paying. I mean, the cap is going to apply very directly to dollars that the county will, that the appraisal district will be receiving, because most cities are going to strive to stay under that cap. So you're going to see a big reduction overall in increases, let's put it that way. So I do think you got to kind of flatten out what we would see in terms of revenue, because people are going to be paying less ultimately in ad valorem taxes across the board. And I think that's one of the things we're going to be hit by that. I think everybody's going to be hit by that, because you're going to see an overall, and the ability to issue debt is going to be impaired directly also by that. So, while we're not exposed to the cap, there's definitely going to be a change in the ad valorem revenue profile moving forward, I think, for all the taxing entities.
The inverse effect is the property values are going to still continue to
That's right.
skyrocket.
We'll just continue to see
They're
values
gonna
go
go
up.
through the roof.
But whether they can, the 10%, there's going to be some balance there.
Yes.
It's going to have to balance its way out over time.
Right.
Just because we're not under the cap, we're still going to be affected.
Yeah, we're going to be impacted by it.
No question.
Because when you look at it, then you get the county commissioners now who have to make the political decision.
So we've got our.
I'm glad we're not under the cap.
So I put this slide in for Trent. This is our,
You got one slide.
I appreciate that.
Don't get too excited.
I think you asked me about this my first year, 4 years ago. This is a very busy slide, but back to Trent's earlier question, how do we determine the breakout of what we call the maintenance and operations rate, the interest and sinking fund rate for our total? Our total tax rate, this is an important slide for everybody, because this is the rate that you will be asked to vote on as we get to a budget approval at some point. We are not requesting or recommending any change to our current overall tax rate, which is that .224429 of $1,000 assessed value. The way that we determine what goes into INS and then the M&O rate is simply the plug on the other side, is what does our current debt service schedule look like? And we give that number to the court, and that's how we differentiate between the INS and the M&O. The reason that that is so important is because if you designate dollars in your INS rate, they cannot be used for anything but interest or sinking fund payments. The M&O rate, however, can be used for interest expense if it does happen. So the INS rate is fairly restrictive.
Here's my observation about it. We're going to be in a situation over the next 3 years where that's going to change dramatically.
It will.
The O&M portion of our rate is going to have to come down in order to support the INS portion of that rate.
It will.
I completely understand and agree with the $22 million designation of the separate fund. My question is, what do we do 3 years from now when we have a new 12 million or 20 million, depending on what we do and how fast we do it? How do we avoid sort of a startling difference in our O&M rate, which to us means a reduction in services? I mean, that's a reduction in services any way we slice it.
Right.
Does that get absorbed by efficiencies? Does it get absorbed by, new revenue streams? What is the thought process? Because to me, I get it. I see what we're doing here, and I know it's a direct amount of debt that we have today, which is still declining. But when we do issue that debt, how do we sort of mitigate that huge difference in O&M and INS?
So from my thought process, that's the 22 million that we've kind of set aside to say, we can do this. We can be disciplined enough to where we're not going to let a lot of little things creep in. We're going to set this aside for the bigger projects. Also, the 12 million or the 12.8 that we talked about earlier that's sitting on the bottom line, that will most likely go back closer to break even. So, and to your point, we are going to have to focus on how do you offset that with new revenues. We might have to look at other service lines that may not have as big an impact on population health, but cost us quite a bit of money. Those ideas are going to have to be vetted out.
That's where, to me, from an operations standpoint, if we spend $10 million in capital over 10 years, that's $70 million on average in operating cost. So not only are we going to see a reduction in the M&O portion based on existing levels, we're going to have the additional M&O burden of serving those new capital facilities.
Exactly.
So to me, it's a double whammy on the
It
O&M
is.
side of the rate.
Yes, and so to your point, the 12 million, in my mind, for next, if you're looking at 2021, the 12 million that's still sitting on the bottom line kind of takes care of that principal and interest, but it does not take care of all the operational impacts that are going to hit us over the next 1 to 5 years.
And that's what's scary, because as the community pressures us to go get these new capital dollars spent and build the bed tower, build what they voted for, we got the other side of that coin, which is going to be, we got to pay for the operations associated with all that.
We do.
And nobody on this board or anywhere else is going to tolerate a gigantic increase in property taxes in order to support that. So I think what unfortunately it means is we got to very judiciously approach this capital spending, not from the standpoint of can we get it built, because we can, but can we afford to operate it? And over the next 10 years, that operating pressure is going to be dramatically higher on us, and that's my biggest concern when it comes to how fast we try to roll out. I want to do it today. The demand is there today.
I
But boy,
think
it's a
that's
scary
what
thing.
keeps us all up at night,
Trent,
yes.
this is the thing that we talked about a few years ago. That's why I'm trying to push for that, so that we, instead of, because we know if we don't see all the numbers on the JPS connection, then the cut and the care may inadvertently coming out of that. So I'm trying to balance out, because the things that when you talk about, fraud, abuse, and waste, you put up a very large hurdle to overcome with the provider. So as we look at those, we can see what's the high yield care, and what's the low yield care. And you get rid of the low yield care, the replication, the unnecessary stuff, the holding on to patient too long before you go to the specialist, drug sign, all that stuff, and then you can take all that stuff and furnish all of that stuff that we're talking about as the years go out. So those are the reasons why I want to see those, so that we can make informed decision. Because you want to provide the right care, but take all the low yield out.
Yeah, no, that's true.
Sharon, let me, something just clicked on me. The 22 mil we talked about, at the end of budget year 20, let's say we didn't have to address anything in that. So we start budget year 21. Or do we start with 20 million?
I would hope so.
And so then we don't have to address that. So at the end of 21, we could conceivably say have 40 million sitting there.
So it doesn't
I'm
quite
just-
work that way, but
okay, I'm just-
philosophically, you're on the right track.
But
Yes, sir.
that's
Yes.
fine. Okay. So,
Well, it's back to what Trent said. If it's specific items within that $22 million, you should, at the end of the year, again, Ralph, give or take, you should know where those dollars are. And when the bond, when the 200 million tranche, or whatever they decide the first tranche is, when's that interest payment going to hit us? You could even have a little bit more. It's a good problem to have. And I use the word problem. It's a position the board hasn't really had in the past. And we will be getting a strategic plan here fairly quick. We will get one ordered here the next week or so. But the reality is that it's a good place for the institution of the district to be in. And again, Trent, you know about this tax question still, the caps, you're exactly right. And I think that ties right back into the strategic plan issue that we brought up. That all needs to be addressed in that. We'll be in the process of putting down RFQ on that real quick.
right, because if we go way back, I'll direct this at Bill, if we go way back, when the financial advisors were talking to us way back at the beginning of the bond, they were building in efficiencies where we could save money. So really, that's what we're looking at on the 22 mil, really is how our efficiencies, as JPS goes forward, how we're able to build that fund to be able to maybe pay for the bond program.
To operationalize
Right,
any new
right.
service, right?
And it also has to do with when, and Trent does this every day, he's chair of planning, but the reality is, what rates are we gonna get those bonds ultimately issued at? I mean, again, it's an assumption.
Sure.
But if we don't get them issued fairly quick in a lower interest environment, which is now, if it waits, so there's a lot of timing issues again, back to strategic plan. I think all that needs to be flushed out in the strategic plan, will be. So.
But I think you're also, as we are looking at that, we've got to know our costs so that we can reduce it. That's the key, is being able to look at your costs, the JPS connection, and then look to see how we can manage and reduce that. I mean, that's critical if you're gonna save some dollars.
I agree.
It is, and we've tried to allow for that more so than we ever have in the past. We've actually allocated personnel in here. It's some of the few FTEs that were added. And again, we haven't gotten to the expense section, but you'll see some more of that. Okay, we're almost through revenue. Federal funding, that's always questionable. I don't really have a lot of news for anything. This is the 11% of our budget, the $119 million. It's made up of uncompensated care, our disproportionate share, and our DSRIP program. We have an uncompensated care. It actually looks like it's increasing 5%, but this amount is actually about $2.5 million lower in 19 because we had an adjustment from 18. So effectively, we're not expecting a whole lot of change year to year in our UC payment. Our dish payment is also staying relatively flat. And from a budget standpoint, you can see that DISRIP is falling by about $9 million. We have there's, of that $9 million, is about an $8.6 million impact because the DISRIP pool is shrinking from a legislative standpoint. So there's less dollars available to grab, regardless of your performance. The rest of that is about a $500,000 impact because last year, the first year of the new DISRIP program, we had a lot of pay for just reporting. And by design, as we start to move more into pay for performance, you rarely get 100% achievement on the performance indicators. So we're doing well on those. It's just a design of the program, as I think the DISRIP will start to change a little bit
So
in
those
the
of us that have
second
been
year.
around here a long time, remember the whole discussion and the explanation of UC and DISRIP? And the explanation was, we're gonna see the federal government continue reducing uncompensated care, but they're doing it in order to be able to give us more dollars through pay for performance through DISRIP. So as we saw UC come down, as our performance improved, and our DISRIP performance has been great, we were gonna see DISRIP dollars take the place of the UC dollars. Any of you, some of us been around long enough to remember that. That's not happening.
No, it's not happening. And, and part of that happening, if you remember, during that debate, there were a lot of hospitals said DISRIP should not be the one that increases.
Well, that's right.
UC should, because we
right.
always said UC is basically
their
block
UC
grants, which we
definition
were
was from here
opposed
to
to.
Atlanta, you know?
I think it ought to be based on performance, but I seem to be a minority voice in the health industry.
I will give you a caveat, just full disclosure, it is written on the page, but there are some changes that are happening in UC over the next year or two where the reporting is projected to be much more favorable to a public hospital because it will just look at truly self-pay and uninsured patients. However, those formulas are still being negotiated, and I have not budgeted for any hiccup on that side. So that could be conservative, but we don't really have a great way to estimate it at this
These are
point.
your budget for 2020, realizing that in September, we'll find some of these need to be adjusted, perhaps more.
Correct. So the only item left is our small other non-patient revenue. You can read through there. There were not any significant changes this year to that either. Ready to go on to operating expense. Does anybody have any comments about the sources of revenue that we have? We covered 4 of them today. So here we go into salaries and wages. Salaries is by far the most expensive part of our budget. It's over half of our operating expenses when you look at it. We did have some increased staffing. You can read down through that list, but we had a full year impact. I've mentioned a couple of new programs and some of the care management for the connection, which, you know, I've heard someone talk about, you need to look at your top utilizers. Well, that's in the plan for FTEs. We're also putting 2 or 3 out at our specialty clinics that, like in the oncology, where it's difficult to navigate and time is of the essence. Some of those expenses have been included here. There's, again, I think in total, there was close to 100 new FTEs that were added from either strategic, regulatory, or new initiatives like in RevCycle. So we also budgeted for a 2% merit increase That's an annual review that each person has. We have, again, I've talked about the rev cycle and some of the newer initiatives. And then we do also budget a pool of funds. This is the same amount as we budgeted last year that we can go in from an HR standpoint and do every 2 to 3 years an overall market assessment to see, has the market changed? This year, the big group of folks that we'll be looking at is our nurses. So that will be distributed at some point during the year.
Is contract labor enough? The contract labor at 1.9.
So contract labor,
That's not enough.
there are a few areas that we use contract labor for, but we typically spend about $2 million a year. So it's enough. That's what we spent last year. I don't have any concerns that that would be too low. So these are our FTEs per adjusted patient day. You can see that typically because of vacancies and other issues that, in 19, we budgeted about 5.7, but we have come in at 5.5. We're budgeting 5.6 in next year.
Sharon, explain to me why you go up. If every year you've budgeted, it was less, 5.54, 5.73, 5.48 is going down, but then you budgeted.
So we did add, if you look at the bottom, about the 100 FTEs that I talked to you about, there were, and I can go quickly through these, but there were about 9 that we added to the baseline because we swapped them out for purchase service. There were 40 in that first expansion and growth for the new MRI, for the emergency department expansion. There's about another 50 that are related to the new initiatives. Revenue cycle, we did add some security officers. There was about 6.2 FTEs for that in some areas that we felt were problematic. The care management strategy that we have, there's 13 FTEs in that, plus another 3, I believe. We had to add some personnel to the lab for a regulatory issue, and we also budgeted for about 20 extra sitters that were also regulatory.
So your total FTEs per adjusted patient day went up because you added those 100 FTEs?
It did, and then there's about 100 in there for some of the volumes. We budget a per hour per unit, so that's how it ended up. We always strive to be below the budget, and we do watch labor really closely.
Well, every year you've been below the budget.
Yes, ma'am.
Way below.
On the previous slide, you had, sorry, I should have asked it then. You said that the market study for nursing and professional staff. What's included in professional staff?
So what I said was, let's see, it was nursing, and so professional staff is kind of non-patient care, so accounting, HR, IT, office support, and professional services are all included for 2020.
Okay.
Next year, management and technical are up, and they look at the residents every year as they come in.
Okay. And maybe I should be asking Robert or Bill this, is how did we get to the merit increase of 2%, maximum 3%? Is that just based on projected revenue that we can afford to do 2 or 3?
So our standard has been, I think when I came, the maximum was 3.5%. Last year, we did 0 to 3% with it, and the 2% is where it averages out historically.
Okay. And the reason I ask that is that I just, in my past experiences, and I'm getting ready to make some good friends out there in the audience.
Now he's working on the left side. Go ahead and see what kind of challenge you put me in now. Our board member said, so go ahead.
I want us to get to a point, because I've seen it happen, where we kind of set a particular percentage, and we look up and we're behind in the market, and then we have to work hard to catch up, and I just think.
So the merit, that's a great point, and I hear that as well. The average merit happens every year, but we have a pretty disciplined approach that all of our job categories from a market standpoint are looked at every 2 to 3 years. So hopefully the marriage of those two help keep us competitive in the marketplace. And even if you're not on the schedule, if something happens in DFW that it seems like we're starting to lose staff, they'll go in and do kind of an ad hoc for that area.
Okay.
Does that
Staff can
answer?
say yay. Okay, all right.
Amanda, did you have a question?
I do. Okay, so you did a great job in committee in preparing us to be overwhelmed a little bit. So I was expecting a 300-page document when I got this. But for future reference, what might help me with understanding like the FTEs, also our competitive salaries, and looking at the combination of FTE and PTEs is maybe having a maybe this goes through HR committee, document that has our salary ranges and what we're looking at to make sure those caps are there.
So that's a great point. We do bring a lot of the compensation issues through HR. Some of the quality issues and metrics go through the quality committee. So in the budget process, I don't mean to underwhelm or not give you the information that you're needed, but it really is more of a financial focus of kind of the plan for next year. And if we, I welcome your feedback if we need to do something through HR or through planning or quality prior to arriving at the budget presentation. But yeah, I'll check with Pia and we'll try to get you some information on what might be coming and when it would be done.
Thank you.
Sharon, did I hear you say that it's 2% to 3%, that 2% goes to everybody?
Not necessarily. Every employee gets an annual review based on their hire date. For the most part, leadership is done each year at the same time. But from a staff perspective, you get a 12-month review. Based on your performance, you get somewhere between a 0 and a 3%. So the 2% is not automatic.
Okay. I thought I heard you say that the 2% was average across the board.
It is on average, and each employee does get the review, but it could be less than 2%, it could be greater than 2%.
And then you talked about the being competitive in the marketplace, and you said we want to be at the top. I hope we meant that would be a desired goal, but I hope we're not doing something that puts us on the top of the spread.
No,
there.
the goal is not to be at the top. The goal is to remain competitive in the market. And depending on the job code that they are reviewing, I think we typically target right around the 50th percentile. There are some categories that are highly competitive that we might have to go above the 50th percentile to target.
Do you do the entire staff from this evaluation standpoint at the same time, once every 3 years, or do you do a period of them every year?
It's a rolling schedule that would hit, I think the longest time period is 3 years.
Okay.
So for IT, they might be done every 3 years. Nurses are done every other year. The residents, because of the way they're hired, are done once a year. So it's on a fairly disciplined schedule, depending on the category. And to answer your question, it's an evaluation of a job class. So that job class would receive a similar increase versus the merit that is based on their performance.
So if I translate what you just told me, you've got a pool for a general increase, and then you've got a pool that would be based on merit.
Correct.
Okay.
Questions?
One quick question here. Looks like there's about 208 more employees added.
Yes.
And we shown a 2 or 3% increase. So that would leave us a pool of about $8 million. Is that enough to hire 200 something plus FTE?
It is.
Which area is that
It
impacting
depends
most?
on the job classes. So a big portion of those FTEs that I mentioned to you earlier were sitters, for example. Those are at a much lower pay grade than our average pay. So some of the FTEs that are new are not necessarily at that average pay rate. So we went in and did a very, it's not just a pool of funds for 200. We actually go in and budget each individual at their average pay code. So it should be enough.
That's a lot of new employee for keeping all service line the same.
Well, and there's always some ebb and flow through recruiting and retention, and we do have a vacancy factor that sits in the budget, and I think that's about 130 FTEs on average.
That makes sense.
Okay. Benefits, those are, the biggest costs are FICA, health, and retirement. So when you look at that, our employees, when you look at the health plan, they have two options from a health plan standpoint. Last year, we introduced a high deductible health plan and kept the PPO option. So as we start to get into the second year of our high deductible health plan, one of the goals is to try to increase the participation into that plan. So we also try to control some of the employee health plan costs. You can see, and I'm just going to kind of run down that list. There's an inflationary increase that happens every year. That was going to cost us about $2.8 million. And most of our 6,500 employees do opt in to our health plan. Also, I think I need to note that we are self-insured for this health plan. So every doctor visit, every prescription fill is $1 of expense to JPS. And so our health plan costs and the education to the staff is really important. Trying to increase the entrance into a high deductible health plan, we also created a health savings account option. Under a high deductible health plan, you pay out of pocket a larger amount than you would under the PPO. But your HSA account, you can actually put and act like a savings account and put your own dollars in there. So when you go and pay your $45 for a primary care visit, you can access this pre-tax dollar. This year, in addition to a wellness credit that they can earn of about $600, if you go and participate, we are going to give you $250 upfront into your health savings account. Some employers give more, some employers give zero, but this is the first year that we are doing $250. Working with our consultants that help us with benefits, we have also identified that our plan still allows out-of-network use. And if we were to restrict to the Cigna network, which is very large, we could potentially save $260,000. So that's not an unusual restriction that is placed on usage. We also identified a drug rebate opportunity that might save us about $600,000 that we put into the budget. And we're also going through a validation of coverage. So if I wanted to, as I continue to insure my kids, I would have to produce a birth certificate that showed me as guardian, legal guardianship for those. Or if you want to cover your spouse, you would also have to produce a marriage certificate to validate that. I believe that we have done that for the last few years when you are initial and new to the plan, but we have not required existing membership to provide that or people who were already on the plan when we started doing that at enrollment. So that is just good practice, and that could save us potentially $780,000. And it would be a third party that would be auditing our staff.
Sharon, we're to assume that all of these changes are included in the budget and are the staff recommendation at this point?
Correct.
Okay.
They are staff recommended changes at this point. And they have been included in the FY20 budget as either cost or savings. The last bullet is, for the last 2 years, we have put a premium increase on the 2 levels of plans that have spousal coverage. As we are self-insured and as we start to look into our high dollar claims, there is a exponential increase on spouses that are covered. But we don't have a large differentiation between the employer contribution and the employee contribution on the employee and spouse and employee family levels. So for the second year, we are going to propose that we increase on the PPO only. There would not be any change to the high deductible health plan option for an increase to help offset some of those costs of the covered spouses. That would produce a savings of about $1.4 million.
Sharon, I have a question for you on
Yes.
the discontinue of out-of-network benefit.
Uh-huh.
The reason I do that is, we're very sensitive when it comes to benefit for our staff.
Mhm.
Is that for them from going out the network?
Correct.
Do we have enough, the Cigna provide enough for people to do appeal based on grievance and all that stuff? Because there's some special cases where they have to seek help elsewhere.
I do know that there is an appeal process within Cigna that you can go through medical directors. And that's not special to JPS. That's just how Cigna administers self-insured plans. We did have our consultant review some of those out-of-network benefits, and the savings is not for 100% of those. It's for the percentage that they feel like can be redirected into a lower cost in-network option.
Okay.
So we did not assume like all of the expenses that were paid out of network would go away. I think that the total cost was well over $1 million.
Probably better manage of nail network, is that what?
I'm sorry?
Better manage of nail network than this.
Yes, and we're not even really talking about a narrow network. We're just saying that you have to go to an in-network Cigna provider, and Cigna has an enormous coverage in the DFW area.
Because some of the things that I'm concerned about is that, let's say they have surgery, and the hospital is in the network, but the imaging or the anesthesiologist may not be in the network, and I don't want to use that as a penalize to our own employee because of that discrepancy that haven't been, I'm not sure who should pick that up from
Right.
telling them that it's out network, because sometimes they just don't know until eight weeks later.
So I know from personal experience, you can, and it always happens in an emergency department, you can go through an appeal process, and in that case, you have to deem that it's an emergent issue that you needed to be there. the out-of-network benefits from a total expenditure is not a big, huge number. It's just kind of an unnecessary number. So that tells me that there are other options that would be in-network. But I believe, and we can double-check that to make sure that that appeal process exists for those out-of-network benefits that might be incurred.
All right, thank you.
You bet.
As a reference percentage, how much is that premium increase percentage for spousal coverage on PPO?
So under the PPO option, I've got a couple of numbers for you. We have a kind of a socially just scale on what the employee portion is, and there's 5 different levels. It starts at under 35,000 and it goes up to greater than 100,000.
Okay.
So if you were to look for an employee spouse in the less than $36,500 employee, if they stayed in the PPO, that would go up an annual amount of $492. So their monthly deduction goes from $252 to $293. If they decided to go from the PPO to the high deductible health plan, that would be a savings of $1,700 on their premium cost. Now, what they would need to do is start to put more into their health savings account. You know, it's not a $1,700 pickup. They would, you know, we've been doing an education now for about a year. So my recommendation was if they felt comfortable with the high deductible health plan, to just start to put that difference into their HSA, and it would build up over a year or two to the point it was fully funded.
How has that been received?
You know, the HSA, from my perspective, went over really well last year. I think we had about 20% of our population move over into that plan from the traditional PPO. 15 or 20, I can't remember.
Thank you.
Now for, you know, and it's a bigger impact as your annual salary goes up, but that's how it would impact that level.
Remind me, Sharon, the HSA, it's rollover year over year for them?
It is, and when you leave the organization, you
It goes
take
with
that money with you for approved medical expenses, which are strictly defined. But yes, you get to keep that, and once you get, let's say you had a $2,500 deductible, if you were able to build that up over a couple of years, then you've pretty much paid your out-of-pocket pre-tax.
And then just one last question on the validation with the third party. We're making sure that that's gone through an equity lens for our non-traditional families?
So from a health plan, and this is not my area, but I can take that back. From our health plan definition, in order to be covered, you would have to be a married spouse or a child that was born to you, adopted, or that you are legally the guardian of. So I don't know if that answers your question.
Somewhat, but yes, I understand the legalities of that.
Okay.
Thank you.
Other benefits are the FICA that goes with the increased salary. Any other questions? Okay. You have a question, Dorothy? Okay. Professional fees are really what we pay to physicians to cover our patients that are seen within JPS. I will say that approximately about half of our total expenditures are paid to our physician group acclaim for $145 million. This includes coverage, GME, medical directorships, the professional fees that we pay on behalf of our connection and self-pay patients. And from an acclaim standpoint, the same exact verbiage is going to be in a claim, so I'll spend a little bit of time on it right now. We have a full year impact of some of the vacancies. You can see that there's some additions for behavioral health. We did add 6 nurse practitioners into the medical emergency department to help navigate as we change some of those throughputs. Occupational and correctional health have increased volumes. Oversight of behavioral health, will be adding a new vice chief and 2 mid-levels, and that also includes some expenses that we spend time with warm handoffs now in the ED over to behavioral health. We do have some independent provider groups. Again, the larger independent groups that we have cover our emergency department. It also is our hospitalists, anesthesia, and radiology. So half goes to a claim, about another 40% go to those other 4 large groups. Purchase service, again, our bigger expenses, our housekeeping, our software fees, collection fees through patient accounting go through there. Outside medical services, which again, we pay on behalf of the self-pay and connection population for services that we do not provide here, like home health or skilled nursing. That category is going to increase about 17 million. Again, a big part is our operational improvement fund that we talked about for yet to be determined projects. If y'all have any questions, please let me know. We're getting into some smaller dollars, so.
Can I go back 2 screen?
Yes.
Can we go back 2 screen?
For professional fees,
No, the one before that, sorry.
benefits,
Yeah, I saw retirement in there, but I don't see any bullet point down here. Is that something we can discuss later on, or?
yes, we can discuss that in closed. Okay, where was I? Medical supplies and drugs. We assumed a 7% increase on drugs, which is kind of our industry average, and that happens year over year. And our other expenses, a lot of our administrative fees, food, maintenance, repairs, utilities, and insurance impact this. I did want to point out on our insurance expense, we are budgeting for a little bit of an increase there. I know it's of interest to a lot of you. We are increasing our cyber coverage. We're planning to increase that based on some recommendations, up to a $30 million limit. Our property taxes are going to increase, or our property insurance values increase, and we haven't had a great insurance year as a state. So we're assuming that we are going to feel the impact of that. And we are proposing to add a new regulatory liability coverage as well to that. Depreciation is simply a function of our capital budget. Are there any questions on the non-operating or on the operating revenue? Our non-operating revenue is simply the investment income that's produced over the roughly $600 to $800 million that we carry every year. It goes up in January, February when we get our ad valorem revenue, and then it slowly depletes over time. The big assumption there is we had predicted 225 basis point reductions in interest earnings. We thought it might happen in September and then another one in December, but we actually had one at the end of July. So one of those has already happened. And so that, when you put all of those numbers together, that brings us back to what I hope is a familiar $38.8 million, or about a 3.5% margin for the medical center. Do y'all have any questions before I start with the claim? Okay. A claim, I'm not going to go over every slide because it's really based on, oh, I'm sorry, I forgot all about the capital. Goodness. So our JPS Future Fund, right now it's sitting at about $131 million. I am proposing that through the budget process that y'all also approve an additional $10 million be placed into this fund. If you recall, based on last year's budget, we earmarked $10 million of our capital to be reserved for this purpose at this point in time. When I cover the 2020 capital budgets on the next slide, I've earmarked another $10 million to help build our cash balance up, and that would be committed this time next year.
Sharon, none of the dollars that you're projecting that would ultimately be in the new fund you've created, none of those presume a decrease in cash balance, right?
Correct.
Decrease in cash balance.
And the 10 million's already in this budget, in the 19 budget.
That's clearly conservative, and I love it. I don't know if it lasts.
We're putting money back, that's what we're doing.
We are, and from a capital standpoint, it's from my standpoint, it's really about cash flow. So if we're planning to build these projects, and we have committed ourselves to several $100 million of, we're going to put it in of our own cash. We started that fund a few years back, and every year in capital, we have been able to dedicate that $10 million. It's not enough, most likely, and it's not something that we might be able to do when the new projects come on. But for as long as we can plan that, it will help us in the long run from that cash commitment. We also have about $8.9 million in facilities and renovation, equipment, IT, and capital contingency. And the way that I get to this $38.2 million is I am funding depreciation, which ended up being just slightly over that, but it's the 38.2. Under facilities and renovations, the bigger things are infrastructure improvements. This is more dedicated for Robert's purview, this $2.5 million. We also are going to be renovating some of our labor and delivery floors within the hospital. Some of the other remodelings are some MRI zoning that we've identified that needs to happen. Additional at the Health Center for Women, the mammography area. We've got $1.4 million in the elevator modernization this next year, and some repurpose of some current basement space.
The elevator modernization in addition to what we've spent this year?
Yes, sir, it is.
And we'll remind you all that we elevated the spending this year. We were going to spread that over time, but you saw the need and we upped that. So we will have 5 modernized elevators by January, and then we'll continue on with that same with the 1.4 million. And if we need more, there's, other discussions we can have.
When does the parking garage shuttle go away?
January.
There is a 5-year plan for the entire facility for the elevator program.
So in the facilities and renovations, is it in there somewhere where we're going to put Burger King since we're losing McDonald's?
Robert, would you like to?
Robert, is there something Burger King in the audience? You want to take the podium? No, I think we're fine, but thank you for your question. I'm going to defer that just a little bit. Let me think about that.
But I mean, we talked about.
Yes, we are. We're having discussions with our nutritional services team and other outside consultants to figure out the best approach we can take to that, which includes ownership on our own or other types of relationships that we will have. Yeah, we've been very upfront. We've been upfront with the current owners and our own cafeteria as well. You just generated 1,600 more emails to my account. Thank you.
He's feisty today.
So for the equipment, I'm just going to point out, we tried to group these so you can kind of see what areas some of the medical equipment is going to. Under nurse call, I believe this is the final phase of that system, and then that will be completely updated this year. IT is about $8.3 million. There's a lot to do with Epic and the application upgrades. And then the virtual desktop, that is also the last of a 3-year implementation. Any questions on capital? All right, let me start over on a claim. You heard from Dr. Hochberg on a lot of the focus here, but a claim is driven by the number of employed physicians. So once I get through the number of, I've got a friendly fly that's all over me. We've got once I cover the physicians, I think the rest of the budget will kind of fall into place and make sense. But hopefully you've read through the highlights. There's a lot of focus on expansion and improvement of services. The top 3 have to do with revenues. There's some staffing, again, for ENT, the surgery group. The one big thing that's happening is the transition of the care connections in street medicine from JPS to a claim. That's about 8 FTEs that we'll talk about, and that is an extension of Joel Hunt's group for the street medicine. We've talked about the benefits of a hospital physician group practice. You can see that our loss per provider this year is $54,811. The 75th percentile for MGMA is almost $57,000. The benefits that a claim provides to the JPS network are really difficult to quantify, but it's the coordination of care, the alignment, our metrics, and the integrated EMR are huge benefits. And again, the drivers for loss per provider, we deal with a lot of socioeconomic issues with some of our patients. The ancillary services are owned by the medical center. A lot of private physician groups are able to own their own lab, radiology, or testing equipment that provide a lot of additional revenue at that level. And of course, our teaching and research component that we have here at JPS also impacts that. So here's a key slide for us. Currently, if you look at that top, our FTEs worked is about 420, but there are 475 providers that are budgeted for in 19. So we're increasing from an expense and volume for about 55 FTEs. Again, these are full-time worked folks. Each month you hear Dr. Hochberg talk about the recruitment, and so we have left that at 475 this year. The new 8 clinical staff are for the street medicine program that I mentioned earlier, and there are not really any recommended changes to the administrative staff.
On the 475, those are including PA and nurse practitioner also as well.
They are. That is total providers. I'm glad you asked that. Of that number, about 60% of those are actually MDs or DOs, and the APPs make up another 40%.
And for that number, that doesn't include the, like anesthesiologists, the surgeons, right? They just.
Okay, so your question, I believe this number would include the surgical group. What was your other question?
No, just like
The surgeons are employed by a claim, yes.
The only one that's not including here is the anesthesiologist group.
The anesthesiologists are not in here, The majority of the hospitalists that, the sound coverage is not included in here. And correct, the ER positions would not be included in here. They are not, but, so these are mainly the employed physician practices. So on my earlier slide, when I was talking about the medical center, this is the 50% of the coverage, and then there's another 50% that are non-acclaim providers of the expense. It's not a number. The 50%, there's not another 400, but dollar-wise, it's kind of 50-50. The encounters you can see are relative to the filling of some of those open jobs in primary care and oncology. Behavioral health also had an increase from a clinic perspective. And often these are, it's not a visit like it is on the medical center. Sometimes the physicians, they are counting encounters for RVUs. So these numbers can be slightly higher than the medical center numbers. Their patient revenue, they have a 7% increase in providers and a 5% increase in net patient revenue.
This, can I go back to that one?
Sure.
Because I'm trying to understand the 80 million. These are net, so we probably collect about 40%, 30%, 40% of gross billing, right? Because the average number the average net revenue for all, for family practitioner is generally about 2.1 million and 2.6 for internists, but average out to be about 2.3. So if I take that number and I multiply that by the 60% of the 475, which gave us about 260, 280, doc, it doesn't add up to be 80 million. That's why I'm trying to question, what's the panel?
So 126 of the 475 are primary care with another 28 of pediatrics and 9 in geriatric. The dentistry program is in there, so the collections are really low for those people.
Okay.
And then there is a wide variety of other, behavioral health has a really low collection percentage, I'm thinking. So I don't know if that is on the same track of your question. But we have a historical collection rate and charge structure for each one of these specialties, and it's done at the physician level.
Yeah. I don't want to burden.
It's just not apples to apples, I think. Like, we're seeing the.
Right, so I think to go forward, I think we need to know the panel and all that stuff assigned to primary care and all that stuff to see where we are, because we can't measure them by what RVU either. We kind of hidden, but we really not apply. So where are we short, where we have more bandwidth and all that stuff, but that's not another conversation.
But we are, I mean, unless I'm wrong, we are monitoring panels and we are looking for efficiency levels.
I can't speak to that. I mean, that would be, I would assume the Claim Executive Committee, that's the work that Dr. Hochberg's doing, but yeah, I mean,
We do. There are targeted, I know I asked the question on a primary care physician, and if I recall correctly, their annual target is about 1,200. But it depends on how many years of experience do they have, what clinic are they at, it could depend on turnover. There are so many factors that go into what their clinical schedule target would look like, but they are developing and have developed those per-day productivity.
Trent, I guess my point was, like, in the setting where it's a multi-specialty group, we can't apply a logic of X amount of doctors times this collection should equal a certain net patient revenue.
What I'm trying to get to is if we accept the MGMA, that we losing 54 was less than the average. So if we accept the denominators, then we have to accept the denominator, which is $2.3 million average billable, and net. So we just need to sync it. Because I don't think they have enough panel. Some may be overworked, some may not. So let's take a look at the panel and all that stuff to see how much we assign per physician. Because if I'm in my if I were in private practice, they want to get at least 30 or 40 patients a day as a primary care. But if we only have 15, we still fill the spot. So I think we're on.
So your question to me is, on the productivity, is looking at what is their panel size for primary care, and seeing based on, if I have this many in my panel, this is my average I see every day.
Right, because if you don't understand the panel, you can't go and get to the patient population assigned to you, and then how many do you need to see annual wellness visit, that you have to look at them, and then how many you can have a PA or a practitioner looking at it so that you can increase the panel but not overwork the doc. Because we have to be concerned about fatigue and all that stuff also as well.
And I would just assume those are happening at each individual service line levels within a claim. Just like in the emergency department, I would be making sure there's a certain amount of productivity that's achieved.
Right.
And all I'm saying is, I just like to see it. All I'm saying, I just like to see
To be
it.
brought to, we'll figure out where it would be best presented,
Okay,
and
all
we'll
right.
get you something. Uh-oh. No, that's okay.
I am in the front row. So yes, the template and the panels were a big project that was undertaken with Community Health and Dr. Duncan and the various service line leaders to align what our access needs are, what is the capacity of our current facilities, and what is the capacity and expected productivity of a particular provider. And so those panels were created specifically based upon all those numbers of expected volume that comes through, experience, if someone is a family medicine physician versus an internist, and that's how the schedules now are built based upon what those expected benchmarks should be for a particular provider to be able to perform. And so a claim does not add any providers into the system unless it is done in an agreement and an alignment with community needs as well as operational needs at the request of the network. And we continually monitor those to make sure that we are in fact addressing that community need. Now, you could always add more hours, you could always add more weekend coverage, and you could always add a whole range of things, but there's obviously a balance there because every time you add a physician, you also need to add the appropriate level of staff and back office support and all those elements there. So it is a very fine balance, but it's something that is intricately looked at and worked on a regular basis.
Is it just possible that for me to get that information, I'd have to come to one of your meetings? I said, for me to understand and get that information on panels and their productivity, I asked, do I need to come to one of their meetings to get it? Because
You need
all
to
I'm
ask one of
saying-
your state representatives.
I mean, I just would, I totally understand what you were saying. I'm a pictorial person. I kind of like to see things that you are saying, this is what it is. I mean, if I need to come to a meeting, I'll be glad to come and get it. I just would like for you to commit that I will see it.
So Dorothy, why don't you let us decide where the best, was that Angry Birds? Blast to the Past, my kids play that all the time.
Yeah.
So let us try to determine what committee that would be best through. It might be finance, it could be quality, and then we'll put it on a committee agenda if that's okay.
It's kind of hard for, because, you know, physician can only be there, but we don't know what's the cancellation rate, reschedule rate, and all that stuff that can affect, because you can see schedule 30, the ding rate and all that stuff. We just don't see it anymore, so we can't question and see. The only thing I can measure is that, okay, here's our loss, or investment instead of loss, and now we're looking at the revenue there, and then the only thing I can apply is how how much we can generate per dollar from the net of gross, whatever that is. And then I can extrapolate to see, are we above average? Are we below average? Is there an efficiency problem, recruiting problem, or system problem that you got canceled, or we schedule people from East Forward to West in Mansfield that can't get there? It's just kind of one of those things.
Yeah, and when the panels were created, and this is probably about 2 years ago, a year and a half ago, where all of that rework occurred, it took into account what was our traditional no-show rate, what was our traditional cancellation rate. And so when you look at our panel utilization, that is something that is ongoing and continued monitored at the provider level as well as at the individual clinic level as well. And to what Sharon alluded to earlier, some of those dollars that we hope to be able to spend will be to look to improve the access question. So we're able to plug in patients into those open slots in a much quicker fashion. I'm going to get some food while
That's a good point.
Yes, thank you.
Good quality.
Yeah, that's where it needs to go. Good point.
All right. So the other component of their revenue, this is non-patient revenue, and again, 93% of their dollars of that 50.7 million are coming from the JPS side. So we've already talked about this whole section on the medical center side. It's word for word the same. There have been some changes in their academic services as roles are closed through relationships with UNT. The physicians are actually seeing more patients, so that's where we're getting some of those increased visits from on the other side. Total comp, we have, again, this is just really based on number of providers, the transition of those 8 FTEs, the staff, and there's no change to administrative staff. So all of this is really a full year impact in the assumption that we are going to have our positions filled next year. Acclaim does actually pay outside medical groups for services. The largest part of that is going to be, you can read through them there, perinatal, nephrology, dosimetry, and internal medicine, certain specialties within that. A big part of the surgeons that had been paid through a contractual relationships are now moving into the employed status. So I believe in this budget, all but 2 surgeons will now be Acclaim employees.
I wanted to, for the purposes of those in the audience and those live streaming, and you board members, I wanted to give you an update. Sharon is now officially at the halfway point of her presentation.
I've got lots of pages.
But I did want to let y'all know that there are a few more pages left, but we can get through this relatively soon, just kind of accommodating y'all's time and knowing where we are and where we aren't, and how many more water breaks you want to take or fruit breaks you want to take. But I did want to let you know that we're getting to the end of this, and then you can ask, obviously, additional questions, anything y'all want to do. Obviously, it's y'all's discretion as to what happens, but I wanted to give you an idea about where we were. So we're almost to the end of this presentation. The slides that are remaining will not take as long as some of the other slides, and then we'll kind of go through that.
Robert, in anticipation of that, the other point being is we do have a closed session. We do need to get to a couple things too, so again, not to speed up, but just to make sure, we hope to take the break maybe in between.
Sure. I've probably got about 5 more slides to cover before I wrap this up. Other operating expenses are a really small portion. You can read through that. No major changes there. So when you, again, once you add all this together, it is our 26 million. Our loss per provider number is down at the bottom. That is not our only measure, but it is an indicator that hopefully gives you some comfort in the way that the budget was developed. By the way, this was approved at the Acclaim Executive Committee meeting on Monday, so they have seen that and moved it forward. They do have a few capital items related to the clinics, the 2 clinics that they own. And I'm going to move on into the foundation. The foundation board also reviewed their budget and approved that about 2 weeks ago. There's a few, I don't usually cover the foundation in much detail at this committee, mainly because it's relatively small, and they do have their own board of directors that oversee their activities and drive some of these budget initiatives. But, just as a reminder, we do have the 3 major functions that happen. They do fundraising and grants. We have temporarily restricted money. And then the Connection Supplemental Program also runs through the foundation, funded by the medical center at no impact to the foundation. Are there any questions? I know that I didn't spend any time on the foundation. Amanda, you may have 1 or 2.
Yeah, I have like 5. No, I really only have a couple. And so this was just saying in comparison to other foundation boards with the hospital, I know we've talked about this several times, at $4 million with the foundation and looking at 11 FTE. I know that I participated in one as a call-in on one of their foundation board members, and they were saying that that number isn't actually the number of all of the activities done from the foundation board. So if you can help me understand that a little bit more, because I will be honest, at a revenue of $1 million with an 11 FTEs for a foundational board, it doesn't make sense.
So part of the 11 FTEs, there's 4 grant FTEs. This is on the last slide. There's 4 in development, and there are 3 that are administrative that kind of span over both of those areas. There is a large grant function that shows up. The expenses show up here. There is a funding of $1.2 million that comes across from the medical center to cover all fundraising, salaries, and operational expenses for those 11 FTEs. There is a large amount of work that the 4 grant FTEs do that does not run through the foundation. That equals about $5 million. And we have to recognize those funds directly by the medical center because of some of the federal funding that goes through those grants. So there is about another $5 million worth of activity that does not show up here, but it's complicated by the fact that those staff are fully funded so that they do net out.
Okay, I remember hearing you say that and look through, and I'm not saying that an 11-person staff isn't necessary, because I run federal grants. Those are horrible for about $50,000. You have to do too much for it. What I was looking at is just what the justification is with those particular, to be a budget of $4 million. Does the foundation staff have a specific fundraising goal that they're going to meet?
They are in the process of developing some of the fundraising goals. We went over a few of those back in a couple of weeks ago. Where did that go? So some of the fundraising initiatives, we did plan $150,000 for a spring event that they were going to do. And the board of directors, at least from my attendance at some of those meetings, they have not really developed any further. You had mentioned in your email a capital campaign. I think that might be a little too early for them to decide what's going to happen there.
Yeah. Just in looking at our UC compensation, everything else with our payer mix, and how the foundation can work through with that, that's one thing that we'll need to also look at, because I feel that the foundation has been kind of pushed to the side a little bit. And so we want to look at what that budgeting and what they can do and what their staff members can also continue to fundraise and to move forward with.
Okay. Thank you. All right, no problem.
Sharon, there's
Yes,
on
sir.
page 57, under the connection supplemental, the
Yes.
533,000.
Yes.
Is that going to change since it's not a mandate anymore?
It's not a mandate.
I mean, the exchange and all that stuff, would that, those people may elected to go into and qualify for the.
So let me
for the,
explain a little bit about what the supplemental program is for. So Connection Supplemental is you still have to qualify just like you would for the larger Connection program, but these folks are actually commercially insured and have some coverage, but most likely have a high deductible plan or a large copay relative to that. So the way that we have to,
Can
since,
we assume those are the exchange that we're talking about?
no, they may not be an exchange product. It could be any commercial product. A large number of them, I would assume, are exchange plans or ACA plans that are available in the marketplace.
It could be employer-based, though, your coverage,
It could.
for a low wage.
Yeah, so it's the same poverty, 250% of federal poverty guidelines is our measure.
I was just assuming that we're picking up for the exchange, and now it's not a mandate, so they may drop it altogether and just go for JPS connection. That's what I was thinking. So that number may go down.
Might not qualify.
So that number, the 550, 600,000, has been pretty consistent for the last 2 or 3 years as far as funding goes.
They wouldn't qualify, would they? If they would qualify, they would be on Connection, right?
So Connection Supplemental is an additional program, and there are, I think, anything over 138% you may qualify under the ACA.
Right.
But 250 if you meet certain other criteria, and it's fairly stringent to be awarded Connection Supplemental. And that's the plan that every December 31st, everyone has to re-enroll. So you kind of have 12 months of coverage or less, and then it's a big effort from Michelle Haynes and her team every year.
It's a good program. I just wondering if it's go up or down.
But how many, averagely, how many folks go through that program?
I think right now we have, let me double check my number. We have, as of the end of June, it was just over 5,800 participants.
All right, thanks.
Last December, it was 6,600. You know, so it bumps up and then, or then it drops off at re-enrollment, and then we build it back up and it kind of drops off.
All right,
Okay.
thanks.
Any other questions on the foundation? That's going to roll us back to the overall that we started with. So we have the network, we have a claim, we also have the foundation for a combined total that's just over 1% operating margin and 2.4% net income. Okay, that is the end of my presentation.
First of all, Sharon, thank you very much to you and your staff for putting this
Yours,
together.
please.
Yeah, we're not saying applauding. I think I'll just make a short statement, and Steve, I know you chair finance. It's been a lengthy afternoon. I know there was some questions, and that's why we're here. I'm sitting here looking at 3 former chairmen of the board sitting at this table. I'm happy to say in the 2020 budget that the $22 million, this quote, account, even though it's a controlled disbursement, the board will be a part of it. Hopefully, we answered what the account is without necessarily specifically answering where those exact dollars, but they are controlled, and they'll be controlled by finance and the board. Number one. Number two is there's an additional $10 million future capital need in this budget. There's the unknown of when bonds may be issued, so there's a lot of factors went into this. So I appreciate the lengthy discussion by this board. If there's any additional questions, that's what we're here for. I think I've also heard very loud and clear, this meeting's over, I've already talked to Robert. We will be getting with the farmer consultants and/or an RFQ, whatever we need to do to get a strategic plan time set. I mentioned that to Ralph, and I know he was chair, and we used a certain group last time. We could go back to that group. It's not from my determination, but we will get something set up on that. But again, it has been a lengthy afternoon, but you know, it's a $1.2 billion budget. And in all of our individual businesses, you know, we got people who sit on cities and other municipal bodies, and again, a lot of work went into this. So again, I appreciate this board. Steve, as finance chair, is there anything else you need to add or anything?
Zim
Oh, I'm
has a
sorry, Zim.
question.
Excuse me.
That's okay. Question, we've been wringing our hands about the bond program, what we're going to do and when we're going to do it. Does it have a period of performance that we've got to have all this done by?
It's a 10-year bond program, and we, as many times the county runs, we can pull down as much as we want, when we want, and how we want. You as a board and the court in cooperation have a lot of discretion in that regard.
Okay.
And I'll just say this, Zim, again, there's been a lot of people associated even back for the bond passage, but as you know, the hospital district has certain commitments with that $800 million, and again, strategic plan, all that needs to be where it's going over the next 5 to 8 years. So, yes, but we have 10 years on the bond. Steve, I didn't mean to interrupt you.
I'd like to thank Sharon and everybody in the organization. There's an enormous amount of work that goes into distilling it into what we see in a nice, beautiful package. Even though it takes 4 hours to go through, just imagine the hours it took to compile this and make some really critical decisions. So, I mean, you know, I as chairman of finance, I look at this probably more than the average board member does. So I'm more familiar with this, or I feel like I'm reasonably familiar with it. So I don't want to rush anything along, but I do feel like we have a clock is ticking and we need to move along. I would suggest, if everyone's ready, that we go ahead and move for a vote and move this forward. Again, I don't want to rush anything through. If we need to have a budget retreat, a budget workshop, you know, Charlie's talked about that, but I would be, if the chairman would entertain it, I would like to make motions to move these things forward.
And I would consider that as I have a motion by Mr. Montgomery.
The discussion, I mean, there's 4 items.
No, there's
Actually, there's 6. They're on the
there's 6.
last page.
They're on the last page of the budget.
Yeah.
Go to the last page of your budget. Some of them are included in with each other, but there's 6 items.
There's actually 6, and they have to be voted on and been advised
Yeah.
individually. Zim, I'll recognize you. I know you had your hand up. You second. I have a motion, a second.
I
Dorothy?
have a question before we vote on this, because I thought we was going to go into closed session on something, but I can ask it in open session. Is all the information on benefits you have discussed, all the changes?
So, we can discuss the item enclosed that you're asking about, I believe. There is no change budgeted for that discussion.
Okay, I'll hold my motion if you want to.
Well, either that, I have a motion and a second. We can, Dorothy, if it's important, we'll leave a motion and a second on the have it. We can go to close, take care of that question, then come back out and call for a vote.
I would prefer that.
Then that's what we'll do. Then, is there any other discussion now? If not, let's take well, why don't we do this?
Why don't we go through the item approval and then go there and then come back and vote for the budget? Because it may be long or short, I don't know.
Well, I think we got some other things in close we're gonna have to discuss. I prefer to have a close, get this question answered, come back and finalize the vote on the budget, then finish the agenda, and then go to another closed DT is the way I prefer to do it, so we don't get it all mixed up. Is that okay with you, Dorothy?
Yeah.
Then, if we don't mind, if we could ask the people in the room, give us about a quick 5 minutes, or whatever time it takes, and we'll come back out. So exactly at 4, we call for go to closed session.
I'm gonna make sure that there's three.
You make sure the motions are right.
Okay.
You're the lawyer.
Okay.
All right, we will now reconvene in open session at 5:12. Before we went to close, we had a motion and a second on the budget as presented. There's about 4 or 5
Yeah,
different resolutions.
the motion on the floor is approval of the fiscal year 2020 Tarrant County Hospital District operational budget as presented.
I have a motion and a second. Any discussion? If not, I'd call for a vote on that. All those in favor say aye.
Aye.
Opposed, no?
I didn't see the motion, I didn't see the motion.
Oh, I'm sorry. It was motion by Mr. Montgomery. It was, yeah, it was prior to close.
Mr. Zimmerman.
Okay.
And it passed 11-0. The next one is,
The
get
appro-
these exact, Neil.
Yeah, it's the approval of the fiscal year 2020 Hospital District capital budget as presented.
Have a motion by Mrs. DeBose, second by Dr. Weber. All those in favor say aye.
Aye.
Opposed, no. Passes, thank you.
Next one is the approval of the fiscal year 2020 acclaimed physician group operational budget as presented.
I have a motion by Dr. Weber. I have
Second.
a second by Mr. Montgomery. All those in favor say aye.
Aye.
Opposed, no. Passes, thank you.
The next is approval of the fiscal year 2020 acclaimed physician group capital budget as presented.
Move approval.
I have a motion by Mr. Bose. I have a second by Mr. Reverend Emerson. All those in favor say aye.
Aye.
Opposed, no. Thank you very much.
Next is is approval to designate an additional $10 million to the JPS Future Fund.
I have a motion by DT, a second by
Second.
Reverend Emerson. All those in favor say aye.
Aye.
Passes.
And then the last motion, recommendation of proposed tax rate at 0.224429 with no recommended changes from the prior year.
I have a motion by Mr. Nguyen, a second. I've got 2 or 3. I think
He's approved the second every time
Yeah.
there's one of them.
Yeah. Anyway, a second by Zim. All those in favor say aye.
Aye.
Opposed, no. Thank you very much. It passes. And again, thank you all to the staff and thank you to this board. I also want to know, again, I'll say it, I know how busy everybody's schedules are. All 11 board members were here today, and I appreciate you taking time to be here.
Can I,
Yes.
Mr. Chairman, ask everybody in the finance department to please stand for the hard work that you all did, and I appreciate it.
Thank you all. And excuse me, and the finance chair should stand. All right. Boy, I've totally lost control if I even had any. The next item of business is item number 12, which is consent agenda. There being no discussion, I entertain a motion.
Move to approve.
Have a motion, Mr. Petty, second by Mr. Bose. All those in favor say aye. Aye. Which brings us down to item number 13, which is our monthly report of legal. Mr. Adams?
And the only thing I have will be my normal report that for the month of June 2019, there were 26 contracts under $500,000 that were negotiated.
If no discussion there, we'll take that report, which brings us back to this time again, where we're going to need to go back into close. And so at 5:15, we'll call it, we're going to take just a short second here to go to closed session and come right back to executive session. Thank you. I have a motion by Dr. Weber, second by Dr. Simmons. All those in favor say aye. Aye. Opposed, no. As we end, I'm going to end with something that Ralph, if there's no other business to come before this board, I do appreciate all 11 of you and the time you've given today and what you do for this board. I think Ralph mentioned this first, and Ralph, if I get this wrong, please advise me, but I'd like to take just a moment, I know we've had a long day, take just a moment of silence in recognition to the victims and their families, not only what happened in El Paso, but also in Dayton. So if we take just a moment for that. Ralph, you're
And
certainly welcome.
unfortunately,
If you want to say that.
unfortunately, the stabbings in California.
Stabbings in
took place
California, the
tonight.
week before that in California also. So we'll take a quick moment. Again, thank y'all so much for y'all's, thank you so much. We stand adjourned. Ralph, thank you.